good program. With this brief introduction, I would like to welcome Dr. Amarnath, who is the opening batsman for this conference, and his topic is going to be advanced regenerative therapy in knee osteoarthritis. Dr. Amarnath is a founder secretary of GOSI. He is actively involved in the management of osteoporosis, joint preservation, and rheumatology. He is passionate about these subjects. Currently, he is the chairman of the IOA Osteoporosis Council. And I welcome Dr. Amarnath. At this stage, all those faculties who have joined here, may I request them to please complete the talk in the allotted time. We will be getting a beep 2 minutes before the end of the talk, 1 minute before end of the talk, and at the end of the talk, there will be long beep. Because it's a very tight program, I request everyone to stick to the schedule. Opening batsman, Dr. Amarnath, it's all yours. Please come.
Thank you, Dipak, for a fantastic introduction, and you deserve, and Dr. Dipak deserves, and the team at Stavya and Dipak's team, with Wishbone and everyone, with Zalak and OrthoTV and Poonam who are online. I thank them before I start, and thank you for making me the Lala Amarnath. Thank you. I'm going to share my screen now. Give me a tick, and I'm here. Hope you folks are able to see my screen.
Yes, we can see your screen.
Okay, I'm going to put it on the PPT mode, and here we go. We okay? We're good to go? Is there a lag?
Yeah, we are able to see you. Please go ahead, Amar.
Fantastic. I was waiting for the green signal. Thank you. Thanks a lot. Thank you. So this is me, and I practice in a couple of hospitals in Bengaluru, which has the trade name or the name as Trinity Central and Trinity Heart Foundation. We have about 230 beds put together, 100 in each and 130 in other hospitals, and 45 ICU beds, as this has been run by a cardiologist, interventional cardiologist, and a team of doctors. So that is where the whole challenge and has been addressed with. And this is a brief where I practice, and I thank Geriatric Orthopedic Association of India and Society of India for giving us this opportunity. Today, we've gone virtual. But yes, not just virtual. We are so happy to be not just over the moon, we are on the moon. Anybody make the decision to do something, even with a failure, even with number of failures, we achieve it. And today, we have shown that happening. And we are so happy for the entire team who has brought this together. Now, we have learned a lot of things in the last few days, few hours. What did we learn in the last few years? We're putting it into action. This is not the end of the world. There's always a bright spot. There is always light at the end of the tunnel. Night is followed by a day, and day is brighter than you can imagine. But yes, we are in a very fragile world. We have learned a lot of things. We learn every moment from everyone. And the interesting thing, the best thing is to relearn from our mistakes, from other mistakes, somebody else's mistakes, and unlearning it, relearning it. That's the key focus that is extremely important for our journey ahead. Now, yes, we did all these things in the COVID time, and obviously we are on the Zoom link and other things now, and we are not going to be exhausted. So naturally, we have timed it to 3 hours plus probably this program. So hope none of you are going to be exhausted on this. Now, today's topic, definitely, no doubt about it. Advancements, it's already there on the screen. I don't need to talk to you about it. Let us understand. Before I go to the osteoarthritis advancement, I need to share and talk what is happening. I mean, we need to go back in time, 5,000 years, 10,000 years ago. As human beings, the Homo sapien decided to walk on two legs rather than four, then the stress on two joints, the major joints started to happen, where hip joints and the knee joints are really, really affecting. The documentation was there in Naiching, in Chinese, where Chipo, and put that in the Yellow Emperor's Classic Internal Medicine book, which has been documented, and we still have that. Now, let us come towards our century. In the Roman times, it was documented, not as osteoarthritis, but some kind of a challenge what is happening in the joint. They did not have the term for that. Now, we're talking 2,000 years ago, 2,023 years ago, that is where we documented. That is documented in Italian, the Materia Medica. It is there, very much available for us. Let us go to come towards our century. What happens in the Renaissance? It was again put up in a big way and documented some sort of a rheumatic and disease kind of thing. Even the rheumatic was not documented, not termed. So these are the things which are there. And this is one of the greatest books we have in our books as first MBBS or even final MBBS or even postgraduate. We see 4 or 5 volumes, and each volume of our textbooks are something like about 2 or 3 kilos or 4 kilos. It's huge, and we have learned so much. This is 7 volumes. Imagine 800 years ago, they had this kind of, and documented, where printing was not there. They have written it, they're writing it. Unimaginable where we have come from and where we are here today. Now, coming closer, in London, and where I worked in UK for nearly 25 years, we have seen this and documented, where they saw a lot of women suffered from this. And even till today, we have that. And it was documented for the shoulder, spine, hands, and other joints were affected as well. They did not know the name for that yet. And it was in 1889, John Kent comes in and says osteoarthritis, and the world knows it today as osteoarthritis. Now, but it was here, the designation of OA was introduced by Archibald, Goddard. So that is where the whole thing comes in. And everything is history now, Now, osteoarthritis we treat in many things. Symptoms are pain, obviously, for patients, it could be tolerate, it could be severe, depending on the deformity, and a lot of changes happen there. And we clinicians diagnose it with our clinical knowledge, history, and radiological, like what we see here. X-rays may be far worse or maybe a little better because patients don't come early. They think, oh, it's just one of things. That is where the whole problem is. So we get to treat advanced knee osteoarthritis or any other arthritis for that matter. Today we are focusing on, in my talk, on knee arthritis, so I'll stick to my knee joint. So this is where we are. And let me take you back a few years ago during COVID time. We did a program where we had almost 1,500 plus doctors on this particular event. We did it twice. Conservative management of osteoarthritis knee during pandemic and beyond. This was written 3.5 years ago, 3 years ago. This is where we come from. And a lot of discussion happened there. I will come to that point eventually. And this was one of the huge platforms that we discussed with, and the changes what's happening and what will allow an alarming pace that changes are happening in the world. So this is where you can accept it or you can reject it. But the change is going to come, and it's there right here, right now. So this is where we are. What do we do as clinicians, doctors, practicing surgeons? We give pharmacological and non-pharmacological treatment. In that, one point I have to make, very, very, very important. American Academy of Orthopedic Surgeons, a lot of guidelines, a lot of benchmark things have been got in for orthopedic surgeons in America and the worldwide to practice. What I'm telling now, there are 3 studies which has been done by India, Bengaluru, by Dr. John Ebnezar and his team at, Vivekananda Yoga Institute, where Dr. Nagaratna and Nagendra have been a part of the entire team. What has happened there? These studies were put forward after a thorough research. And what happened? AAOS takes it and takes it as 3 strong recommendations out of the 7 and top recommendation. Mind you, the first time in the history of India, this has been done. Nobody in the country has done this in the past. This is the kind of study, how strong the study is. Now, the recommendations for conservative management and surgical management, it's already there. I don't want to take you too much there. And number 10 comes there, where we put PRP. We are talking about growth factors, which is so limited. And throughout the country, people are using it. I have used myself in my patients, and we have seen challenging results and questionable, doubtful results. And many don't even have the research on that. Let us not fly there. Surgical recommendations have been given very, very clearly. I'll not get into that deeper, but it's there for us to follow and take it forward. Now, in non-pharmacological, for the last 35 years, while I was in Vienna, Austria 2 years, and in UK, and when I came back to India, I have been using unloaded brace. These are just a few to show what the unloaded brace looks like and what can be done. Now, we also give intra-articular injections to the joint with steroids, and we've seen the rectified effect which is happening there. And AACR, ULR has shown us all these things.
Dr. Amarnath, 2 minutes.
Thank you. Appropriate therapy has been given to us. Now, shared decision is the most important thing. Now, with this, we need to give. We did all these things. We have all the implants available, the best things available. What happened? We have the joint, we have the gold joint. All these things are there. Now, we have been addressing just this, but we never address the disease. We are addressing the symptom. Here we are. We have the stem cells, which are available. There are different varieties, totipotent, pluripotent, multipotent. And this is where we come from. This is the cells which are addressing. In osteoarthritis, when we infiltrate, when we graft stem cells, the regeneration happens in a massive way. We have got a very, very good available 2 varieties. One is autologous from your own and allogenic from the donors. The study is there. We've done the studies. India has given a fantastic platform. 15 years of study has given us this particular. I'm showing you the slides basically to show all these things have been done. We have taken the pictures. We have assessed the graduate data and available with OMAC, Western Ontario McMaster from Canada, and mapping of the cartilage has been done. And I will show you the next slide. You can see that here, before how it was in the baseline, and after 2 years, how the cartilage has grown. This is the biggest thing. In placebo, it is not much of changes there. So this is where the whole thing's coming in. And the conclusion has been given. Government of India in 2022 gave the permission for that to be sent. Yeah, 30 seconds, I'll finish it. I'm giving you this slide because in the past, we have shown this surgery which is happening day in, day out. Thousands and lakhs were happening in a year. Now, this was cut off by one simple remedy, cimetidine and ranitidine. This is what I'm talking about. Is this the future, which is available off the shelf? And we can also have your own stem cell from your body and take it. For your smooth knee joint, if you want to have it, this is the best available treatment. You can take it. It is not an idea. It is not just that. It is reality. You need to take it. Today, we are changing the history of knee replacement. We are already there, and I have done the most in the country. And with this, you still have doubt. I agree with you. And probably you might have understood, not understood. 12 minutes is not sufficient. This is just a window to show you and take it forward. Talk to your doctor and make sure we make this better for you because joints are supposed to be moving. With this, if I can make a 95-year-old hip move and the knee dance, why not? You and me. With this, I end my talk. Thank you. I'll stop sharing now. Thank you.
Thank you, Dr. Amarnath. Dr. Jha is our second speaker. Can you? He is the going to talk on the inflammaging, how it concerns the geriatric bones. Dr. Jha is a past president of the BOS, and he's actively involved in the ortho-rheumatology subjects. Patron and founder president of the Indian Ortho Rheumatology Association, Secretary General of the Asia Pacific Society for Foot and Ankle, and he has been past president of the Indian Foot and Ankle Society. And his subject is inflammaging, how it concerns geriatric bones. Dr. Jha, can you please share your screen and start your talk?
Right. Thank you. Thank you, Dr. Dipak. Friends, where has it gone? Something went wrong. It was there. All right. Is it visible?
Yes, yes.
Okay. So my topic is inflammaging, how it concerns geriatric bones. Friends, as we are into geriatric practice, our geriatric population mostly develop inflammaging. And this terminology was coined in 2000 by Francesi et al. And he said, aging process has chronic, progressive, pro-inflammatory phenotype. And it is characterized by elevated levels of all the inflammatory markers, out of which important ones are interleukin 1, 6, 18, TNF, interferon, gamma, and microRNA, etc. Now look at this half globe, and you will appreciate that apart from genetic predisposition, apart from this genetic predisposition, there are changes in the gut and microbiome permeability, chronic infection like HIV and herpes-like virus, and intrinsic cell defects are responsible. But what is most important is the central visceral obesity, which gives rise to so many things. So central visceral obesity itself can produce oxidative stress, which is caused by dysfunctional mitochondria. It can get into NLRP3 inflammasome activation. It can produce senescence, which is either cellular or paracrine. Then visceral fat tissue and adipocytes have their own role to play. So let us come back to obesity. Now, obesity is a very great contributor to adipose tissues because these adipose cells, they hypertrophy. And as we can see here, these adipose tissue in the visceral body fat, they increase the body weight and simultaneously are responsible for adipokine production. Similarly, even the bone marrow fat, they also are responsible for adipokine formation and also the intra-articular fat. So finally, what we get because of hormonal changes and aging in bones is osteoporosis. What we get because of repeated minor trauma and aging and various other factors is osteoarthritis. Well, friends, I will take you little towards osteoarthritis, what Dr. Amarnath has just been talking about. We were not agreeable initially to the inflammatory theory being responsible for production of osteoarthritis. So it was only during 1990s, much before inflammaging was postulated, that the molecular biology discovered inflammatory theory in production of osteoarthritis. So many soluble mediators such as cytokines or prostaglandins can increase the production of matrix metalloproteases and which degrades the chondrocytes. So friends, It took us 10 more years. So the theory of inflammation has now been accepted beyond 2000 in causation of osteoarthritis. So what happens? Lifestyle, pollution, chemical changes, ailments, even medications that we have been using, they trigger oxidative stress and result into low-grade inflammation, leading finally to metabolic syndrome. Now let us understand for a moment what metabolic syndrome means. This means type 2 diabetes, heart disease, and stroke, either alone or combined together, that constitutes metabolic syndrome. And what are metabolic factors? They are abdominal obesity, high blood pressure, impaired fasting glucose, high triglyceride level, low HDL cholesterol levels. When inflammation sets in, it is a risk factor for evolution of so many diseases like cardiovascular disease. It has a casual association, but chronic kidney disease, diabetes, cancer, depression, dementia, sarcopenia are definitely because of this. In this half globe, you can see that inflammation produces all the diseases that I have enumerated. Anemia becomes very important, sarcopenia and osteoporosis, what we are left with to tackle in the bones. As you can see, there is high susceptibility because of inflammation, leading to chronic morbidity, disability, frailty, and premature death. Friends, we can see that the systemic effects of inflammation could result into sarcopenia, anemia, insulin resistance, osteoporosis, even neurogenesis, and mitochondrial function and biogenesis. So let me take up anemia. There is direct inhibition of iron absorption and recycling, plus there is erythropoietin production interference. Similarly, the inflammation is associated with resistance to anabolism in the muscles, and that is due to inhibition of perfusion adjustment to anabolic system and inhibition of insulin-like growth factor production signaling. So let's talk to what we want. Friends, a lot of work is going on longevity regulation. So there is a drug known as rapamycin, which is inhibitor of mechanistic target of rapamycin, and this has got anti-inflammatory property. Longevity regulation has been proved both in animals and humans. This improves survival and health, definitely in animal model. Aspirin has been shown to improve lifespan in mice, not in humans, but metformin has been shown to improve lifespan apart from its anti-inflammatory effect, apart from the effect that it has on diabetes, the health span gets increased. So it reduces all causes of mortality and diseases associated with aging. So this one is a very important observation. Rapamycin is produced by Pfizer, so it can compete with metformin in providing longevity to our patients. Now, what is the hypothesis? The hypothesis is that inflammation can produce cardiovascular diseases, multimorbidity, frailty by inhibiting growth factors, increasing catabolism, and interferes with homeostatic signaling. But this requires confirmation in humans. It will require clinical trials whether early modulation of inflammation prevents or delays the onset of cardiovascular and musculoskeletal frailty. Friends, thank you very much. I will stop sharing.
Yeah.
Right.
Dr. Jha, it was a wonderful things. I think a lot of new things we have learned from this, and more so ever, you have finished well in time. So certainly it will help. Our next speaker is Dr. Bharat Dave, who is the one of the co-organizers with me here from Ahmedabad. Very eminent spine surgeon nationally and internationally, having a big institute where there are 3 OR machines and advanced robotic spine surgery, and has been a national and international faculty for AO and many other spine surgery meetings all over the country and abroad. And he has a special interest in the minimal invasive surgery and osteoporosis. Dr. Bharat Dave is going to speak on slides. The enabling technology integration in the surgical treatment of aging spine. Is it needed? So in the geriatric population, the newer technologies, newer machines, how they are going to be beneficial. I think that's what he's going to focus on. Dr. Bharat Dave, please.
Thank you, Dipak Bhai, for the introduction. Thank you, Dr. John, Ebnezar, and Dr. Amarnath for giving me the opportunity. It's been wonderful working with you, both of you, and Dipak Bhai has been my mentor from my residency days. I'm going to talk on the technology. These are my disclosures. We have a team of 6 spine surgeons working together, and this makes our life easy, smooth, and we have a kind of subspecialty unit at our hospital where we have like cervical spine deformity being done by different consultants and led by different consultants. I'm going to talk on the my screen is coming. Yeah, okay. Okay. I'm going to talk on this age quake. Age quake, we know that we are in the era of the aging population. This enabling technology, why do we need that? The enabling technology integration in the surgical treatment is required because there is aging population which is all around us. I'm sure each one of us have more than 60, 70 years of an elderly gentleman or lady, mom, grandma in our family. So this global population has increased, and this has increased the demand and effective and efficient treatment for the age-related population. So technology integration is important, and it plays a crucial role in improving the outcome and quality of the care of these elderly people. Someone had held my hand earlier. I need to really hold his or her hand today in order to keep them going in the best possible physical and mental state. That's what we should all be concentrating on. Osteoporosis being the major challenge, and it's a hidden enemy. So, and it leads to low velocity fracture. So these are the main 4 items which we really are bothered about, and there is very little you can do for that. At least you can just delay, or when it has come, you can really, treat their osteoporosis along with the sarcopenia. Another condition, degenerative disease, aging, crooked deformity with the musculoskeletal involvement. That also is something which is bothering us the most as well in the today's clinical scenario. And that is where, we are challenged by different kind of situations when we plan to operate these patients. Malignancy, it is something which is now with the advent of chemotherapy, lot of malignancy have good outcome and can be treated very well. But sometimes the decompression is required, sometimes the alignment is required in order to maintain the mobility and to give them the neurological deficit less. And other comorbidities along with that, these are the areas where, we really need to work on. And preoperative clinical radiological correlation and planning is very, very important in order to optimize the function, reduce the risk factor. And I think we must have the risk identification and scoring system, which are all available. But are there anything that we can do for the per-operative surprises which may come along when we operate? And that is where this integrated operation theater suite will be of great help. And what does that mean? This is the term which is coined at Xavier. We have class 100 OT with the mobile CT scan machine, with the navigation tool, with the neuromonitoring, and with the bone scalpel and the gadgets which are all integrated along with the 3D 4K exoscope as well. So all these gadgets, we consider them integrated into the one room, and where we call this as a magical room, where we can operate anything, and that we can have the per operative surprise can be circumvented by there. So that is what we have. As Dr. Dipak Bhai mentioned, we have 3 OM, 3 navigation, and recently we have the robot as well. So we have named them as Nandi, Jamban, Airavat, and similarly, the navigation also has been named according to our all the satellites as well. And the robot is also named as Ganesha as well. So this is what, Brahmastra, 3D 4K. So these are the kind of thing which we have integrated in our operation theater. And we have these 3 suits as well. As the aging population is increasing, we really need to have this used as well. A lot of specialty being used, ortho surgeons, trauma, joint replacement, they all use the robotics. But along with the navigation and 3D CT, and for the spine, what we need is IO-NM integration as well. What I have not included in this talk is the 3D printing, which we do not practice at the moment at Xavier. So coming to a case scenario, 2007, look at the DEXA scan. This was -4. And she was advised to start teriparatide. But unfortunately, she took it for a month and afterwards she stopped. So we really need to have the defaulters in the treatment. We should be really addressing them. And look at 2007 and 2014, she continued to have the treatment or other the mobility. But in 2014, she comes back with the quadriceps weakness. Now, this is where the challenge comes. She already had one L2 fracture. Now, the new MRI shows L1 fracture non-union, a level above. And this silent fracture, in spite of no treatment taken, had healed. In spite of -4 DEXA, she was okay managing well. Now, if you look at this, she had to be treated with multi-level fixation. Now, this was possible with the enabling technology. We managed to put the screws in such a way so that you can see here, we have redirected the screw in such a way so that, you can have the maximum grip. And we were able to put the bicortical screws as well. And over and above to that, after surgery, we had the CT scan done, second spin. So that also gave us the perfect. So we do not need to bring the patient back. And this is something we can achieve with the enabling technology. So she's coming regularly for the follow-up. I would like to put a small little word here. Sequential therapy is must for osteoporosis. And this is very important. Those who are treating osteoporosis, as we know that this is a geriatric society and we all are going to age, we really must be treating with the sequential therapy. Osteoporosis is a lifelong disease and we must address this in each meeting in order to not to have this group of patients suffer from osteoporosis or osteoporosis fracture as well. Coming to the second case, look at this C4-5 instability. This patient had Klippel-Feil syndrome with myelopathy. And look at the patient who had the DEXA scan, which was also quite low. Now, what do we do for such patient? With the crooked deformity, degenerative scoliosis at the top level, the scoliosis at the cervical level. This was a nightmare. And he had the neurological deficit and quadriparesis. And that is where the enabling technology came to our rescue. And we were able to put the pedicle screws, decompress the spine, as you can see in these X-rays. And this is the last film which we had. So this is something which you can achieve. And patient came walking recently with just a stick. So this is where the technology helps us in planning the treatment and in giving the best possible outcome. Another group of patients, 84-year gentleman, had ankylosing spondylitis, had lower level fracture, as you can see here below that. And we ended up putting the pedicle screws as well. So that is where the technology helps us too. And so there is how a patient was treated with the pedicle screws as well. So coming to the IoT SS, the last few slides, I think what we need is integration of the technology, which is most important. It gives the best possible outcome. It gives us the precision and safety. With advanced technology, it enables the surgeon, and particularly in osteoporosis and degenerative disorders, we are enabled because of the technology. It gives us the precision and safety. minimally invasive techniques which can be implemented that reduces the trauma and decreases the pain and leads to faster recovery. Most important is the surgeon and the whole team does not get radiation, because when the CT scan is being done, you are out of the operation theater, and so there is zero radiation to the surgical team. So IoT observers, they will say it's a disruptive technology because you have to keep upgrading, which I would certainly agree to, because you have to upgrade as well. Why don't we all upgrade our mobile, we all upgrade our car, why not our operation theater? That is where our most of the time is being spent. It prevents the deadly complication. It says the surgeon's heartbeat, because when you are operating like this second case, you are around the vertebral artery and the spinal cord and you're putting the screws into the pedicle. So certainly our heartbeat is saved, and it is adds on to all the possibilities of the surgical technique, and it ensures the best care and clinical outcome. Limitations are there as well. Basic open technology is going to be a problem. We baby boomers are all going to really need to learn all this technique, but it is not something which has a very high steep learning curve. You can very well do it without major issues, without major training as well. It depends on the technology. We really need to have the dependent on the technology could be one of the thing. So that is why, we really need to learn it in a different way. One may say it's a market-driven need upgradation. Yes, it is certainly market-driven to a great extent. But what we have found at Savia, it has changed the clinical outcome to a great extent, and we keep upgrading as well. So zero radiation, non-users will say. So in conclusion, it's enabling technology, growing healthcare, comorbidity, patient safety, cost effectiveness has to be tightened accordingly, because each one of these comes with a cost as well. But that is something which we can overcome, because at the end, you have given the best possible outcome to the patient. After instrumentation, you do the second spin. Limitation and dependency has to be considered. You are responsible for what you do, but you are equally responsible for not doing something that you should have done. This is the sentence. If you keep it in your operation theater, that will give us the best possible outcome as well. A physician can bury his mistake. An architect can say that, you can plant some things and posters, but a surgeon won't be able to change. It will be evident on the imaging. So beware of this imaging, which is going to be taken tomorrow by our colleagues, and that can be prevented 100% by the technology as well. Thank you very much for patience hearing. Thank you, the GOSI team, and thank you very much for the opportunity given as well. Thank you.
Yeah, not on time, Bharat. Thank you. A quick question. You said sequential therapy. So it is always better to give denosumab after teriparatide. The reverse is not true, correct?
Absolutely right, Dipak bhai. The reverse is not true at all. Denosumab is something which should be taken with a pinch of salt. And I think initially bone forming agent has to be given. And then afterwards, we can take over to the denosumab, which is anti-resorptive. And the most important thing, if you stop denosumab, then the new fracture will occur as well. So that is very important. So it has to be followed. If the denosumab discontinued, it has to be followed by the anti-resorptive alendronate or zoledronic acid.
Fine, thank you. We have a small message from the Secretary General of IOA, Dr. Naveen Thakkar, who is the GOSI member also and the Gujarat Orthopedic Association's active member and a past president. So he has just requested all the viewers and the members. He's contesting for the election of the IOA. So this is a small message from him, which I am just displaying here. I thank at this stage our two partners, Stratos and the Acumentis, for supporting us as an academic, and of course OrthoTV for making this live to wide coverage to the orthopedic surgeons. The next founder president's lecture is from Dr. John Ebnezar. I don't think he needs any introduction, being a founder of the GOSI and a Padmashree awardee and Dr. B.C. Roy National Awardee. There's lots of things there under his belt, with number of books, the Guinness Book World Record, and his active participation in the GOSI in making this geriatric orthopedics very popular in India. He has done a lot of hard work for that. So I take this opportunity to welcome Dr. John.
Thank you, sir.
And for his bioethical issues in geriatrics. John, please.
Okay, can you see my slides now? Hello?
We can't see your slides, no, sir.
1 minute, 1 minute.
Yeah,
Can
it's
you
come
know?
now.
It has come?
now.
Yes,
Okay.
it has come now.
It has come.
Okay, thank you very much, sir, for this introduction of yours. And I am indeed grateful to Bharat and Dipak for coming out with this excellent online GOSICON 2023 11th International Conference in such a short notice of time. And they show their enormous capacity to do things at such short notice. Thank you very much. Now, is there anyone in this audience who would, who want to die, who can escape death? Well, even, Jesus Christ could not escape death. The slides are not moving.
Sir, click anywhere and then it will move. Now it should move, sir. Click anywhere.
Okay. So this, this bar is coming on top. I don't know how to, remove that from there.
It will remain there because we are speakers, sir.
No, but it is blocking my slide.
I know, sir. Put it on the right side or left side.
I drag it.
Yeah, sir. You can drag it, please.
How do I drag? 1 minute. Yes. Yes. Thank you. So when we are on the verge of quitting the world, what is that one thing we all want? And who gives us this? We all want a dignified death or exit. And who gives us this dignified life and exit in our old age? It's our elder care providers. Definition of aging. Aging can be defined as the time-related deterioration of the physiological functions necessary for survival and fertility. Elder population, what does WHO data say? According to WHO data, population over 60 years will nearly double from 12% in 2015 to 22% in 2050. What are the legal and ethical issues in the elderly? What is the difference between the two? Legal standards are based on written law, while ethical standards are based on human rights and wrongs. Something can be legal, but ethical. Legal standards are written, by the books, while ethical standards are written by the societal norms. Ethics in geriatric practice, role and importance. It refers to a framework or guideline determining what is morally good or bad. In the world of elderly, it is more significant due to two reasons. One, elders are more vulnerable. Second, elders are taken advantage by many. Ethics is necessity in our medical profession and more so in geriatric patients. The ethics of medicine is based on these four principles. What are they? Autonomy, beneficence, non-maleficence, and justice. Ethics means different to different people. For the elder, it is how they wanted to be treated and allowed to make their own decisions. For family members, as caregivers, it is about doing right when no one is looking for it. For professionals, it is adherence to established norms laid down by the law. 4 common ethical issues confronting elder care providers: actual conflict of interest, potential conflict of interest, confidentiality, and the actual conflict of interest when elders' wishes clashes with the spouse's wishes, family members from different generation, fiduciary, that is the guardian and the conservator or agent, and care providers' business. Potential conflict of interest, consider these situations. Potential, a power of attorney signed by the elder to run his business when he cannot. Perceived, the elder is now incapacitated and the son now seeks the rights to be transferred and gifted to him. Actual conflict, if the son acts within his power to impoverish the father's will. So what was not there in the beginning, potential, may later become actual conflict when the elder's interest diverges from the caregiver's interest. Confidentiality, keeping it private. The belief that what you tell your doctor will stay private. decision-making capacity. Practice the elder-centered approach. Elders may or may not have the capacity to make decisions. Elder care providers have a duty to focus on elders' needs. Best interest of the elders must be weighed heavily in all decision-making. Principalism is the ethical framework, and it has got 12 essential principles. Now let us examine each one. The first one, autonomy. Respect for the following elders' choices. Inherent right of self-determination, right to consent and right to refuse the diagnostic workup and treatment. This includes protection from unwanted touching, right to be educated on the pros and cons of a medical decision. Autonomy of the elder is the first essential principle. It is a basic human right. The elder's autonomy must be respected to the extent possible. Conditions essential for autonomy: liberty. The patient should have liberty, independence from controlling influences, capacity for independent decision making and intentional. For example, a 70-year-old who is suffering from cancer may refuse the invasive treatment and opt for alternative therapies, or another elder may choose home care over nursing care. We need to respect that. Autonomy versus surrogate decisions. Surrogate decision making may be used when a patient's wishes are unknown or unclear, or the patient lacks the capacity. Autonomy, when does it end? Autonomy ends when a patient's request breaks the law or jeopardizes the public health or safety. For example, smoking in one's room in a LTC facility. Informed consent. It's an important part of autonomy. It refers to elders' capacity to understand and give consent for medical services. They need to be educated about the available options and the probable consequences. Personal autonomy is free from controlling influences. They need to be respected, whatever is their choice. Informed consent, decision-making process if elder is in a fit condition. Surgeons and anesthetists explain the risk and benefit. Adequate information to be given. Allow the patient to make a decision and then accept that decision. If the patient is unfit to give an informed consent, here the autonomy cannot exist, exercised by surrogate, moral or legal agent for the benefit of the elder. If there is an ethical dilemma, when elder lacks capacity and the surrogate has conflicting interest, then autonomy is weighted against the principles of non-maleficence, beneficence, justice and sanctity of life. It is the elder's wishes that needs to be exercised. Medical decision making for a potential incompetent patient. If incompetent, identify appropriate proxy. If proxy is unavailable, use best medical judgment while locating the proxy. This concept of advanced directives, what I call a living will. Here the elder creates and signs a directive for future course of action when in full and normal sense. It includes medical power of attorney and advance directive to physician family surrogates. Elder can express his intentions and have an assurance decisions will be maintained and respected. Advanced directives are written statements of a person's wishes regarding medical care. It is a formal, legally endorsed document that provides instructions for care. It's called a living will or names a proxy decision maker. AD for end-of-life decision. The elder can express his autonomy before the need for resuscitation arises. Do not resuscitate order can also be willed and can be a blessing if he wishes not to suffer the trauma of repeated attempts of emergency to restart the heart or breathing. Relief for the family who do not want to witness such vain attempts, to avoid unnecessary financial burden on the family. And if the resuscitation becomes successful, the patient becomes vegetative, so he doesn't want the resuscitation to be done. So beneficence, fourth one, to good. Do right. It is to do good. It is the act of doing good to others, to help them directly and avoid harm. The physician's main concern should be the welfare of the patient. When does the beneficence trump the autonomy? In a life-threatening emergency, if elder is unconscious, surgery may be performed before obtaining the elder's consent. Here, the intention is to save life. Principle of beneficence is put into practice here. Beneficence was paternalism. It may easily interchange. Paternalism is intentionally overriding of one's person's known preferences or action. Caregivers like physicians, nurses, social workers, by their superior knowledge and training, are better positions to determine what is good for the elder themselves. To avoid harm, they may override the elder's preference. This may cause emotional or psychological damage, if not physical. Example, a 75-year-old is advised immediate surgery without giving full information of the procedures, the reason, risk, benefit, cost, complications, etc. Though the intention is to do good, it could be damaging to the elder. Today's managed care industry gives less time to the physician to talk to the elders in the end of life crisis, aggressively oppose the autonomy of the patients and their desire to continue life-sustaining treatment. Non-maleficence involves doing no harm and avoiding negligence that leads to harm. Justice, focus on fairness in the treatment for elders. This concerns allocation of limited health care resources, how to approach giving health care to elders with limited budgets, use the utilitarian ethical viewpoint to allot to do most good to for largest number of people. Idealistic approaches, resources are used for the most deserving. Sanctity of life, there should be inherent dignity, care and respect. Confidentiality, you should not disclose the privacy of the patient. Disclose it only with appropriate consent by the elders. Physician-patient relation should be based on fidelity, trust, confidentiality, and protection from intended harm. Truth-telling, physicians have a duty to tell the truth and be honest. Integrate into good bedside manners and patient support. Technical terminology should not obscure. Communicate an honest estimate of prognosis. Futility of treatment, know when to stop. Treatment should be consistent with the patient's goal. Assess each case individually so as to determine whether treatment would be beneficial. Avoid interventions that would not benefit the patient and or prolong suffering. Non-abandonment, duties of physicians to uphold the principles of fidelity, not to abandon the patient after establishing a therapeutic relationship. May voluntarily terminate care of a patient after the patient proxy has been informed, after providing a reasonable amount of time to make other arrangements. To help with such alternative arrangements when there is a conflict between a patient proxy and a physician concerning a course of treatment, guidance is obtained through the ethics committee, ombudsman, or law. Limited resources, handle with care. Ethical dilemmas, central to the practice of elders treatment. Ethical dilemmas when ethical problems arise, when there is a conflict about what is the right thing to do, whether or not to hospitalize. It may disrupt their daily routine and may cause falls. Though right to put them into a hospital, you may decide otherwise, unlike in young adults. These considerations may make decisions about OPD treatment very complicated. In a person with malignancy, should this person have chemotherapy or not is a dilemma. And other dilemmas are nursing home or home care. And home care, over 29% do not desire to be in the hospital in old age. They would like to die in their home. Nursing home care, ideal but expensive and undesirable to most. Enteral feeding, it is acceptable to withhold treatments such as IV fluids, antibiotics on request of the appropriate proxy decision maker when life prolongation is no longer the appropriate goal. This is my own example. My home atmosphere, my father, just 5 days before, he passed away at the age of 86. He preferred to be at home, though it was very critical. He was happy amongst his family members, and he passed away very peacefully in the home atmosphere. This is the advantage, of being at home with proper care than being in the nursing home in their final moments. And there is a risk when you opt for home. This is an example of a slip and fall at home proved lethal for Vani Jairam, a 78-year-old lady, a very famous Indian singer who fell to her death unattended due to a forehead injury at home. This is a likely possibility, but still much better. Problems of long-term nurse care system, a non-system. It is mostly an institutional care, though it would be cheaper, better with home care. Physician-assisted suicide, a strict no. It is a collision between the principle of autonomy and respect for sanctity of human life. Even for those who are approaching the end of natural means, it is not right to assist anyone to take life. It is a red line that we must not cross. We should do nothing to purposefully speed the death of a patient. Assisted suicide and euthanasia, it is illegal in most countries. What are the legal issues for elderly care? The power of attorney, writing a will, advanced care directive, or living will. Act of negligence, malpractice, and omission. Negligence is the failure to exercise adequate care. Malpractice, it is a negligence on the part of the professional person in providing care to another person. Negligence, the omission. It occurs when something you omit that is ordered or expected as a normal part of treatment for a client. Intentional torts, acts by a nurse performed with the intent to bring about specific result. Assault in an attempt to or threat to injure another person. Battery is unwanted or unconsented physical contact. Defamation, written or spoken communication that holds a person up to a ridicule or scorn and tends to harm his or her reputation. Libel is a written defamation. Slander is a spoken defamation. Invasion of privacy, violation of a person's right to be left alone or to enjoy reasonable non-interference with his or her life. Elder abuse and neglect. Elder abuse can be defined as a single or a repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust which causes harm or distress to an elder person. It is prevalence and incidents difficult to document as both victim and abuser deny or minimize the problems. About 4% of the elderly are abused and 1 in 60 cases is reported. And the types of elder abuse being physical abuse, psychological abuse, emotional abuse, financial, material abuse, sexual abuse, and neglect. Abandonment. It occurs when dependent person or person responsible for care leaves the older person physically, emotionally, and financially defenseless, waiting to die. Better place, nursing home or home. That's the dilemma. You should not abandon. So how do you detect the abuse? Red flags. When the patient comes to you alone without a caregiver, delayed presentation of illness, recent fractures, unexplained falls, risk factors, stress, alcohol, violence, emotions, dependency, dynamics in the family, history. Always interview patient and caregiver separately. When possible, an in-home assessment is preferred. Ask the patient, has anyone ever hurt you? Has anyone ever taken things without asking? Have you gone without food, medical aid, or medicines? Physical examination. Look for bruises, laceration, abrasion, fractures, neglect, poor hygiene, stress, malnutrition, psychosocial agitation, passive, withdrawn, depressed behavior, sexual abuse, difficult in walking, sitting, etc. So prevention of abuse to increase public awareness and knowledge of the issue, community resources and safety plan, elder abuse intervention team, social worker and police detective assessment, emotional support, follow-ups, safety plan, seniors abuse helpline, home care, lifeline, day program, enduring power of attorney, personal directives. There are 10 safety plans which we should teach the elders to safeguard themselves. What are they? Teach them how to call the police. Teach them how to keep a written journal, date, time, description of events. Teach them to inform someone they trust. Teach them to have someone stay with them in their old age. Teach them the importance of communicating acceptable boundaries and rules. Teach them to secure their home, change the door locks, telephone numbers. Teach them to secure their mails, secure bank accounts, credit cards, ATM. Counsel them to have a plan next time if abuse happens. Advise them regarding senior safe houses. Finally, tell them how and when to get a court protection order. If you do this, then the dignity and the life of a senior citizen is safeguarded in today's turbulent times. The take-home messages to you all is ultimate goals at the core of geriatric medical care is their well-being for all. Elder care providers practice collaborative approach. Apply the principalism, an elder-focused approach, the 12 points which I enumerated. No substitutes for these in old age, especially spending time, talking and listening to the old age people, which will enhance the quality of life. Talk therapy, no substitute in geriatric patients. We may have the most modern gadgets, but if you don't talk to the geriatric patients and counsel them, then all the advancements, all the treatment, all the so-called innovative skills, techniques are of no use. Compassion and humanity. Look at the agony of this lady on her face. Will she be able to exercise the autonomy? No. Surrogate care becomes very important. No mercy killing for vegetable existence. Allow them to pass away peacefully. Uphold their dignity till the end of their lives. A parting shot about elders. Who are elders? Our elders are not our burden. Rather, they are the most lovable and respectful in our life. They are the knowledge bank of our culture and traditions. They teach us the moral values and many good things. They gave us the knowledge about what is good and what is wrong. Ethics in geriatrics in a nutshell. Simple formula. How do you want your father and mother or grandparents to be treated in their final stages? Do that for your patients. When we deal with our elderly parents or relatives, no need to teach us ethics for us. We follow the ethics automatically. It occurs naturally. The same thing we are supposed to do with the patients. Treat them like your family. Then there is no way you will go wrong ethically or legally. So, founded Geriatric Orthopedic Society of India. I invite you all to become GOSI to be a part of the GOSI family and become members of GOSI. Next GOSICON 2024 will be in Srinagar. Please participate in big numbers. Dr. Ghulam Mir and Dr. Suhail Afzal will be doing the honors, and our own Dr. S Jha will be supervising the entire conference on his own, and he has agreed to be part of GOSICON 2026 in Patna. So we congratulate this entire team and we look forward for great events. I am a recipient of the 4th highest Indian Civil Award and highest award in the field of medicine in India. Thank you, Team GOSICON 2023. Thank you, Bharat. Thank you, Dipak. Thank you for your excellent team. There is no word to thank you, because you saved us from a catastrophe, and we are happy that we have been able to put a big and a very successful event. Thank you very much.
Yes, thank you, Dr. John. It was a very philosophical thought-provoking, combined with the science.
Thank you, sir.
For the geriatric population, which we have been seeing all around us. The next speaker is going to be Dr. S Mohanty, who is the professor at the KM Hospital, Mumbai, and past president of the Bombay Orthopedic Society, past president of the Indian Arthroplasty Association. His special interest is in the PJI, the prosthetic joint infection, and he is the designer for the innovative cement spacer, which is quite cheap, very effective. He's got the best paper awards for so many conferences like AAHKS, SICOT, IOA, and he's also the one who is going to be standing and asking for support for his the next IOA election. Dr. Mohanty has been a very active member for the GOSI, and I request him to present his talk. Dr. Mohanty.
Thank you. Thank you, Bharat Bhai. Let me share my screen.
दीपक भाई के भरत भाई मोहंती किसको तुम बोल रहे हो यार?
I am sorry, Dipak Bhai. Dipak Bhai, sorry. I was just going to thank Bharat Bhai also. My screen is visible. Is my screen visible and am I audible?
No,
You are audible. The screen is visible now.
Yes. Now.
Am I audible and visible?
Yes.
yes.
Okay. So, good evening to you all. I am really thankful and grateful to Dr. John, Dr. Amarnath, Dr. Dipak Bhai and Dr. Bharat Bhai for giving me this opportunity. A topic which is very close to my heart is periprosthetic joint infection. And I am going to talk about debridement, antibiotic irrigation, implant retention, which is the procedure of choice in the early periprosthetic joint infection. And here the meticulousness which is matters for the success to save the joint. Now, friends, this is a procedure which is done when there is an early post-operative. There is some network issues.
Just a minute.
Okay, is it visible now?
Not yet.
You need to. Yeah, it's visible now.
The screen is visible. Am I audible?
You are
Yes.
audible. The screen is still not seen.
Yes,
Yes,
now
it
it
is
is
seen
seen.
now.
Should I stop share and again? Now it is in. Okay. Sorry about the trouble. Actually, I am at a Maharashtra Orthopedic Association conference at Jalgaon. So network is little bit a problem here. Okay. So to continue, it is indicated in early post-operative infection when the joint age is less than 3 months or in late hematogenous infection within 3 weeks of onset of the symptoms. The best results are always happens when there is short duration of symptoms with a stable implant inside with a healthy surrounding soft tissues in an immunocompetent host. So it should not be done as an emergency procedure, rather it should be kept to the next available routine theater to be done. When not to do, when there's a chronic infection, presence of a sinus tract like this, and whenever there is a loose prosthesis like this, obviously you are going to take out the prosthesis and do a two-stage procedure. Here, this is not indicated. But better to avoid in rheumatoids, inflammatory arthritis like rheumatoids, when there is a high ESR of 60 millimeter, more than 60 millimeter, when there is a duration of symptoms are more, and whenever there are resistant organisms like MRSA or gram-negative bacteria. And the organisms which shows poor outcome is Staphylococcus. The unfavorable results are 55 to 57% of cases. Gram-negative bacteria, resistant Enterobacter or Enterococcus, they show poor results compared to Streptococcus and other organisms. The technical aspects here that always explain mentioned about possibility of explantation. That means on the table, you may decide to take out the implant and put a cement spacer, because if you see the prosthesis is loose, do a thorough debridement, do a radical synovectomy. You have to here really ruthless to take out all the synovium, etc., and take out the mobile parts like polyethylene insert and put a thicker insert. That's why you need to plan that you keep to have the trial inserts as well as the original thicker inserts ready on the table, and curate out that metal, cement, and cement bone interface, because there the granulation tissues erode into the bone osteolysis. So you have to meticulously divide that area and take out that material for culture sensitivity. Send culture the synovial fluid as well as the inflamed tissues. Any unobserved suture should be removed completely, and do a copious lavage using a normal saline of 6 to 9 liters. And these are the steps. Do a thorough debridement, suprapatellar pouch, parapatellar gutters, and next take out the polyethylene and reach the posterior aspect of the joint and do a thorough debridement of the posterior synovium and posterior aspect of the joint as well. And as I told you, get out of the cement bone interface and metal cement interface and take out these materials and send it for culture sensitivity. Nowadays, we are getting the culture bottles inside the theater itself and put the retrieved samples inside the culture bottles and send it. Sorry, again got disconnected. Is the screen visible again?
No, screen is not visible. Yeah, away now.
Yeah,
Yes.
it's visible now.
Yeah, my apologies for the technical issues. And then give a thorough wash with a betagen, hydrogen peroxide, and pulsatile lavage you can use in low pressure, and put some probiotics like gentamicin or so in the pulsatile lavage. And next, suture with a monofilament nylon rather than braided sutures. The adjuvants to debridement, as I told you, you add some kind of antibiotics, gentamicin or cephalosporins, and use pulsatile lavage in low pressure. And nowadays we are adding an anti-biofilm agent like acetic acid, benzalkonium, or chlorhexidine. Normally we add around 30 ml of chlorhexidine to a 3 liter normal saline. And then you put local antibiotics in terms of calcium sulfate pellets, antibiotic integrated calcium sulfate pellets, like we add 10 grams or 10 ml of stimulant with 2 grams of vancomycin, around 240 milligram of gentamicin, and then put these pellets in the suprapatellar pouch, parapatellar gutters, as well as into posterior aspect of the joint. This 67 years old female, rheumatoid, diabetic, hypothyroid, and these 2 months following the Dyer procedure, there is no recurrence of the infection. And this is again as you see that there is a exchange of the polyethylene. This is a 56-year-old female bilateral sequence. Left knee got infected. Dyer procedure was done, and this is infection-free in 4.5 years follow-up. And that is the function. This is after the infection had set in, and after the Dyer procedure, this is almost 4.5 years follow-up. So there is no recurrence of the infection. Antibiotics is the most controversial issue. You can continue initial therapy, start with a broad spectrum antibiotic, then continuation therapy depending upon the culture sensitivity report. You should continue antibiotics which has got a high oral bioavailability and antibiotics who has got anti-biofilm activity. Usually the rifampicin has got anti-biofilm activity for gram-positive organisms, and quinolones like ciprofloxacin have got a anti-biofilm activity for gram-negative organisms. The duration of antibiotics should be given 6 weeks to 3 months. Use ESR-CRP as a prognostic marker weekly after the Dyer procedure. Whether to go arthroscopic Dyer procedure, it is not recommended at all because it doesn't allow adequate debridement. You can't reach the posterior aspect of the joint with a scope, and also exchange of polyethylene is not possible and hence not advocated. The failure of treatment is considered, the success is considered when there is absence of infection 2 years after the Dyer procedure. Early failure is considered to be failed to achieve infection control, and late failure is is considered when there's a relapse after initial good response. New and more resistant organisms are emerging now. There is a prognostic scoring system known as KLIC scoring. So KLIC scoring is that if the chronic renal failure score is given 2, liver cirrhosis, in next surgery is a revision surgery or prosthesis for femoral neck fracture, cemented prosthesis, or the CR value is more than 11.5. So if the KLIC scoring is more than equal to 4, the failure rate is more than 60%. So you can prognosticate with your patient that what is the KLIC scoring. The future perspective is that now we have divided the biofilm as a younger biofilm or a mature biofilm. The antibiotics become more sensitive or to the biofilm in a younger biofilm. So if you address or do the diet procedure in the early stage of the disease, the younger biofilms are better attacked by antibiotics. But if you delay it, then biofilm becomes mature and antibiotics do not act. There are research going on whether to find out whether in anti-biofilm antigen which can be given along with the diet procedure so that it will be more effective, and whether to do a in vivo disruption of the biofilm. Our series of diet procedure between 2000 to 2018, 42 patients, 24 hips and 18 knees, and our success rate is 32 out of them are free of infection at the latest follow-up, and 1 primary knee died, of course, of septicemia, rheumatoid, uncontrolled diabetic. And most of the organisms are coagulase negative staphylococcus, more than 45%. And we used the ESRCR as a prognostic marker. And we compared with the contemporary literature, and our result shows that more than 76% success. Coagulase negative staphylococcus is the most common organisms. Knees have got poorer outcome compared to the hips, and patients who have got a high ASA grade have got a poorer outcome compared to patients who have got a low ASA grade. So to conclude, dear friends, the dire procedure, debridement, antibiotics, and implant retention is indicated in acute postoperative infection within 3. Sorry, just the last slide. Okay. Post-operative antibiotics should be given 6 weeks to 3 months. The progress is monitored by clinical examination and inflammatory markers. Patients with immunocompromised, MRSA, poor local soft tissue condition, and failure of one dire treatment prompts a revision arthroplasty.
Your screen
I
is
thank you for a
your
patient
screen
hearing.
Is not seen.
Yeah, you're able to see now?
No, no.
Okay. You're able to hear. I'm just concluding remarks I'm giving that
Yes.
post-operative antibiotics are given for 6 weeks to Again, I thank you for a patient hearing, and I've completed my talk, and I request all of you who are members of the Indian Orthopedic Association for your kind support for my endeavors for Vice President of IOA this year. And my humble request for your support in very much. Any questions, I can take it right now.
Thank you, Dr. Mohanty. By the time the next speaker gets ready, Sanjeev, I have just only one question for you, Dr. Subhranshu. Do you send the poly which comes out for sonication all the time, or only when there is no culture available report? Do you use the poly for sonication?
Yeah, in every place the sonication procedure is not available. Only at few hospitals it is available. We send the extracted prosthesis usually, from the usually in 2-stage procedure we send the extracted prosthesis for sonication procedure. But in dire procedure, I have never sent the polyethylene for sonication.
Yeah, Dr. Jha, you are going to say something. Yeah, you unmute yourself. You unmute yourself.
Oh yes. Dr. Subhranshu, when you say the patient should not be immunocompromised, Would you elaborate?
Yeah, patients are immunocompromised means patient who are with anti-immunosuppression medication, with HIV positive, rheumatoids on methotrexate treatment. These are the patient with anti-cancerous treatment. These are the patients who are immunocompromised, as we tell. And
Sanjeev,
many of the old age patients also beyond 80, 85 years, those are the usually immunocompromised.
Okay, thank you very much, Dr. Sanjeev. Patnaik is the next speaker, and he is the senior consultant orthopedics and joint replacement at Apollo Hospital, Bhubaneswar. He's honorary secretary of the Odisha Arthroplasty Association, and he was the organizing secretary of the GOSICON 2016 in Bhubaneswar. His talk is in take care in valgus knee. Usually we all see the varus deformity more common. And is valgus knee still a challenge in 2023? That is his talk. Sanjeev, please share the screen.
Just a minute. Peter. On call, no? Okay. Hello.
Yeah, we can hear you. Yeah.
Is my screen visible?
Yes,
Yes,
it is
yes.
visible.
Go ahead.
Thank you very much. At the outset, I would like to thank the entire GOSI team, especially our national president, Padmashree Dr. John Ebnezar, and our national secretary, Dr. Amarnath, to give me this opportunity to speak in the GOSICON 2023. A special thanks to Dr. Dipak Dave and Dr. Bharat Dave and the entire team of OrthoTV for giving me this opportunity to speak in this program. So this is the outline of my talk. I'll be speaking on total knee replacement in valgus knee. Is it still a challenge in 2023? So this is the outline. To introduce the subject, we all know that valgus knee constitutes about 10 to 15% of our clinical cases. And total knee arthroplasty in such valgus knee continues to be a challenge. And these deformities are very uncommon. Hence, we are less familiar with these type of deformities. The pathoanatomy needs to be addressed intraoperatively. The valgus knee is not just the opposite of varus knee. And there is no fixed consensus regarding the surgical approach, the type of sequence of release, and the type of implant that we can put into. Now, the etiology of valgus knee, we all know that most common is osteoarthritis, but the other etiology is rheumatoid arthritis, post-traumatic situation, metabolic bone disease like renal osteodystrophy and rickets, poliomyelitis, and sometimes in overcorrected HTO. Now, the challenges in valgus knee, because of its complex altered pathoanatomy, we also have a challenge which surgical approach we need to take. And the rotation of the components is often difficult to ascertain. There is also a difficulty in medial and lateral ligament balancing, the flexion extension mismatch, and leading to an unstable joint. There is more chances of patellofemoral maltracking because of the increased Q angle. And there is also a potential threat to the peroneal nerve and what type of implant we need to use. Now, the bony deformity in valgus, usually there is a posterolateral femoral condyle hypoplasia, and there is concomitant erosion of the lateral cartilage. There is a tibial central bone resorption, and in severe cases, to add to it, there can be tibial torsion. Tibial tubercle is sometimes positioned laterally, and metaphyseal valgus remodeling is also seen. Now, patella malalignment is often subluxated laterally, and the lateral facet of the patella is deformed with having large traction osteophytes. Now, coming to the pathoanatomy, the contracture and tightening of the lateral structures, especially the posterolateral capsule, the LCL, the arcuate ligament, popliteus tendon, the IT band, and the lateral intermuscular septum, all these are contracted. And on the opposite side, we have an attenuated MCL and sometimes in a deficient MCL in severe cases. Now, preoperative evaluation is very important. We have to examine the ipsilateral hip, the ankle, the foot as a contributing factor to the knee pathology. The alignment of both the extremities have to be seen for any extra articular deformity. The stability of the joint in the coronal and sagittal plane has to be seen. The posterior structures have to be examined for any popliteal cyst. And radiological evaluation includes a full-length weight-bearing scanogram, AP, lateral view to see the patella position and tibial slope, and skyline views are also very important. We also need to do stress views also. Now, Ranawat's and Krakow classification 2005, there are 3 types as we know. Type 1 are the 80% of the cases where it is minimal and correctable valgus with a femorotibial angle less than 10 degrees. And type 2 is the partially correctable valgus, 10 to 20 degree femorotibial angle, but we have an attenuated MCL but still functional, and it constitutes about 15% of cases. And the fixed valgus, which is more than 20 degrees, defective MCL, fortunately, it is less than 5% of cases. Now, what to look for in a valgus knee? We have to find out whether it is a fixed valgus or a partially
15 to 20 degrees of valgus.
Now, if it is a partially correctable valgus, then probably we can use our normal instrumentation. Now, coming to the surgical technique, we need to know which approach suits the best, the bone cuts, soft tissue balancing, and how to tackle the patellofemoral tracking. Now, surgical approach, most important, the gold standard is the medial parapatellar arthrotomy, but sometimes it has disadvantages like patella tracking. The mal tracking is more common. There is increased potential for inaccurate flexion extension gap balancing, increases the external rotation on the tibia. That is, the access to the tight posterolateral corner sometimes can be difficult, and the vascularity to the quadriceps patellar tendon mechanism and the lateral skin is at risk. Now, coming to the lateral parapatellar approach, it was popularized by Keblish et al. It had improved access to the pathologic posterolateral corner. It preserves the vascularity because the medial side is untouched, and it centralizes the QPT mechanism, which optimizes the patellar tracking. But it is not routinely used. There is chances of damage to the genicular artery, and we are not familiar with the exposure technique, and there may be a possibility for TTO. Now, the concerns regarding the soft tissue coverage after the correction of deformity sometimes can be a possibility. Now, coming to the bony preparation, especially in the femur, what are the things we need to do differently? The intramedullary rod placement is slightly medial to the patellar groove. The femur cuts are difficult to ascertain due to the hypoplastic lateral femoral condyle. The valgus angle in the femur is set to 3 to 5 degrees. Now, using the posterocondylar axis in the posterior referencing, it can lead to malrotation of the femoral component. So we have to rely on various other things like the transepicondylar axis, the white side line, and we have to keep parallel to the tibial cut surface. Now, femoral preparation, in some cases, the resection from the femoral side results in minimal or no resection from the lateral side of the distal femur. And the femoral component alignment is very important because we need to attain equal flexion extension gap, a normal patellofemoral tracking, and the joint line level. Now, the tibial cut should be orthogonal to the tibial mechanical axis, and it is referenced basically from the medial tibia. 9 mm of bone is resected. And if there is bone defect, it can be addressed with either cement, screws, bones, or augments. And the MCL must be protected at all times. Now, soft tissue balancing is one of the most important part in the valgus knee, the key component in achieving a good functional result and knee stability, providing ligamentous balance with rectangular flexion extension gap while maintaining the lateral stability of the knee in flexion. And we had all the releases can be full release, partial release, or Z lengthening. And it has to be done in a stepwise fashion, reassessment with lamina spreader after each step. And there is still a lack of consensus in the algorithm of the lateral release. Now, there are various papers to highlight all these sequence of lateral release, but the basic thing is that this is the sequence. First osteophytes, then the IT band of the tibial joint line surface, that the posterior joint line, then the posterior capsule of the femur, then we move on to the PCL, popliteus, posterolateral capsule, LCL, in order to increase the lateral space. So this is how one should go in a stepwise fashion. Now, the soft tissue balancing, the LCL and popliteus tendon, they provide lateral stability in both flexion and extension. And the IT band and the posterolateral capsule, they provide lateral stability only in extension. And we release the IT band at the Gerdy's tubercle, lengthening by pike crusting at the joint line. If more correction required, then we need to go for a posterolateral release, but we have to be beware of the peroneal nerve. So release in flexion first, then proceed in extension. The biceps and the lateral gastrocnemius head release are rare options. Now, this is the sequence. Tight in both flexion extension, we can go for LCL popliteus release, then the IT band release, posterior capsule release, and finally the lateral gastrocnemius release. If it is tight only in extension, the IT band release, posterior capsular release, and then all these will lead to a constrained condylar knee that we have to keep in stock. Now, to deal with patellar maltracking, correct femoral component rotation is important. We'll have to lateralize the femoral component, externally rotate the tibial tray, retinacular release may be required, and tibial tuberosity transfer in extreme situation. Now, these are the certain guidelines which are there. Do not internally rotate the femoral component. Do not medialize the femoral. You have to keep it central or lateralized. Do not internally rotate the tibial component. Do not leave the leg in net valgus position and avoid lateral placement of the patella. Now, MCL, if it is too lax, there is a procedure of medial ligament advancement described by Krakow. It should be done when the medial ligaments are too lax after a complete release of lateral ligament. And either we can go for a proximal advancement of the femur or a distal advancement on the tibia. And it has to be performed only after final implantation of total knee, just before the closure. Now, there is a pike crusting technique, Ranawat et al. It is best suited for correction for mild to moderate fixed valgus deformity and performed with a laminar spreader distracting the femorotibial joint. The transverse incision made in arcuate complex at the level of the tibial bone cut, and multiple stab incisions need to be given. Now, but you have to be careful. It should be limited to less than 5 mm inside out technique. Otherwise, you can damage the peroneal nerve. And you have to use a laminar spreader, and in a stepwise fashion, you need to open up the lateral side. Now, lateral epicondylar osteotomy using computer navigation has been promulgated by various authors, but I'll not go into that detail. The choice of implant will depend on the collateral ligament and extensor mechanism integrity, the degree of bone loss, and residual bone. And there is no consensus in the implant. Mostly it is the PS knee or the LCCK. Sometimes you may require a rotating hinge knee prosthesis. Now, so various designs are there, but we have to keep the minimum constraint, and rotating hinge knee is especially for a fixed valgus knee. So I'll just skip a few examples. This is a 67-year-old rheumatoid patient, windswept deformity. As you can see, the distal femur cut. And this is the final picture in the post-operative X-ray, clinical photos. Now, 57-year-old rheumatoid patient, stiff valgus. This is the position, flexion deformity, as well as a valgus. And this is how it has been bailed out. This is the post-operative X-ray, and this is one side, left side, which has been done. Now, another valgus knee with bone loss. I'll take just another 1 or 2 minutes. And this is again another valgus case. Another case, intraoperative video, see the amount of valgus opening. But it is a partially correctable valgus, and it has been done. And this is the immediate post-operative in day 2 post-op. And this is the 1-week follow-up of the same patient. Another case, 67-year-old female, rheumatoid.
15 to 20 degrees of valgus
very difficult
on the left knee,
situation,
full extension,
but partially
and
so we have done one sitting at a time, left side first, and then followed by the right side. A very good patella alignment, as you can see, patella tracking is very nice. Okay, so complications. Sometimes we can have this risk of dislocation, soft tissue instability, patella maltracking, peroneal nerve palsy, although less than 1 to 2%, wound complications, and recurrent valgus deformity. Now, algorithm in grade 1, medial approach, lateral release, PS knee. Okay, just a minute. Grade 2, medial approach, lateral release. If tight in flexion, LCL popliteus PLC. In tight in both, then LCL and popliteus. And in severe cases, we have to go for a CCK knee. So take home message, it still remains a challenge. Multiple surgical techniques have been described, but we have to adhere to a stepwise approach to the deformity correction and implant selection with appropriate constraint, the least constraint recommended for a satisfactory long-term functional outcome. So thank you once again. I would like to welcome all for the IAACon 2024 Bhubaneswar, and also seek the support for IOCon 2025 in Bhubaneswar. Thank you very much.
Thank you, Sanjeev. I think a very difficult topic because it's not a very common deformity. in our day-to-day practice, but you have nicely illustrated how to correct the deformity with algorithm approach. And I'm very sure it will be helpful to all the people, those who have listened to that. The next speaker we have is a young surgeon. I'm not very sure, but probably he's on the GOSI panel, probably for the first time. He's Dr. Abhay Allens, a young dynamic surgeon. He's a head of the department Orthopaedics, All India Institute of Medical Sciences, Jodhpur. His area of interest is pelvic trauma and arthroplasty. Being a HOD and the chair in the AIMS Jodhpur, you can understand his academic achievements and the way in which he's been working there. I invite Dr. Abhay to give a talk on a very difficult subject of total hip replacement in ankylosing hip. Abhay. Abhay, can you hear me? Abhay, can you hear me?
I think we have lost his contact because
No,
he was.
Abhay is still there. Abhay is still here, but
Okay.
I can see him. He's still there, but somehow the network issue, I think, probably causing
Maybe.
this little challenge for him. Abhay, we can see your screen.
We can't see your screen. We can't see your face.
While he's getting ready, can we get on to the next speaker if they are available?
No. He said that he has joined. We can't see him.
We had
Correct.
earlier seen him, but I think we have lost. Maybe connectivity
He's
issues
still on
are
the
there.
link. Yeah, he's still on the link.
Yeah.
Now he is exited. Or you can
No,
see
no,
I
he is
see him
there.
now.
Yes, very much visible.
Yeah. Abhay, can you share
Welcome,
your
Abhay.
screen now?
1 second, sir. Can you see my screen, sir?
Yes, we can.
Yes.
Moving fine.
Yes.
Okay, sir. I'll unshare.
No, you can start your presentation. We already introduced you as a young dynamic orthopedic surgeon with lot of academic inputs. AIMS, HOD, Jodhpur. I have already given your introduction.
Sir, 1 minute. I'll just put the earphone. 1 second, sir. Do I start speaking, sir?
Yes, definitely.
1 second, sir. I'll first go back to my first slide.
Yes, you can start.
Good evening. My extreme gratitude to Professor Jha and Dr. Dave. And my brief is to talk of total hip arthroplasty in ankylosed hips. So what we are actually talking about is total loss of hip motion. And the reason why a hip will have a total loss of motion, that is an ankylosis, will be either spontaneous causes or post-surgical causes. Spontaneous causes, essentially angsponds, RAs, JRAs, post-septic sequelae. And the post-surgical causes are essentially septic fusions, post-tubercular fusions, and post-traumatic fusions.
Hello. Seri hoytu Mahesh. Barta
So
ide.
why total hip arthroplasty?
Yeah.
So essentially, you've got to look at a hip like as a hip which would have ankylosis in the correct position or an ankylosis in a malposition.
Others, please unmute yourself, please.
So a hip which is ankylosed in a correct position, always reconsider your decision to do a total hip arthroplasty because that hip will function beautifully. The problem is where the hip is ankylosed in a malposition. And that is where certain other issues come up. And those issues are altered biomechanics because of the altered spine hip knee axis, crippling low backache, disturbed activity of daily living, issues with knee pain on the contralateral side, gait anomalies, and a lot of psychosocial issues because of this. So we'll start with the 23-year-old male who had a history of morning stiffness lasting 40 minutes, difficulty in walking with restriction of bilateral hip movement for 7 years, backache while sitting and getting up from sitting position, and altered ADLs and unable to work. This patient had a hip which was fixed, right hip which was fixed in 20 degrees of flexion and adduction, and the left hip which was also fixed in 20 degrees of flexion and adduction. Very poor visual analog scores, Harris hip scores, a very poor altered quality of life, SF12s which were indicative of significant disease, HLA-B27, ESR, CRP indicative of a high disease activity as the ASDA score said. So the issues which we need to deal with in ankylosed hip situations are that they are technically challenging. They have patient positioning issues, anesthetic risks, implant positioning issues, and what do we see in terms of long-term outcomes in these hips. So the technical challenge is that there is a bony deformity. A lot of times there is soft tissue contracture as we had in our patient. They have protrusios, which are often grade 2 and grade 3. They have a osteopenia and a bony atrophy. And very often they will present with pathological fractures resulting from decreased hip motion because of ankylosis and bony atrophy. A lot of these patients have positioning issues because of pelvic obliquity. Some of them will be fixed pelvic obliquity, abduction, adduction in the coronal plane, and deformities in the sagittal plane like a fixed flexion deformity. A lot of these patients have loss of spinopelvic motion and a hypo or a hyperkyphosis of the lumbar spine. And as you would see, there is a lot of literature which actually talks of what are the tenets and nuances of doing a hip in an ankylosed situation. Anesthesia issues. These are certain issues which are not very well talked of, and they are very, very important. So patient positioning for rheumatoid arthritis, for regional anesthesia, and we need to be very careful that we talk to our anesthetists that they do not hyperflex these patients to give anesthesia. The position is best tried once in sitting position. Otherwise, the anesthesia or the regional anesthesia should be given in lateral decubitus position. Because very often, if you have an Anderson's lesion in the ankylosed spine, that would result in a patient getting up with a paraplegia, which is disastrous. The other thing is that these are difficult intubations, and fiber optic bronchoscopy and guided intubations are required. So you need a very equipped anesthetic team, and you need them to manage lung capacity and medical management also for these patients. Implant positioning and cup positioning choices depend upon spinopelvic mobility, spinopelvic balance, abductor incompetence or competence, version, sizing issues, and impingement issues, and the choice of stem and the version of the stem. So the technical issues with the surgery were the approach. We need to do an adductor tenotomy because of the adduction contractures. Sciatic nerve is usually anterior. The neck cut issues, very often you'll need an in situ neck cut. The anterior capsule is hypertrophied and thickened. The landmarks for cup reaming and positioning may not be present because there is a hypertrophy and osteoarthritic changes in the tal as well. Dislocation is a real risk, and femur side specifics need to be addressed. So this was the immediate post-operative picture of our patient in question. 2 months down the line, we planned for the contralateral side, and this is what his contralateral side looked like. So we did an impaction bone grafting, and we were able to recreate symmetrical hips on both sides and a very happy patient. So a lot of these patients, very importantly, will take time for their abduction contractures to be stretched out. So you need to emphasize that in post-operative period, you need to do abductor strengthening and abductor stretching exercises, and they will ultimately do well. The important thing in the surgical technique is that these will be operated like, I'm a posterior surgeon, so we will do a lateral decubitus position. The hip flexed and abduction will need to get done first rather than the hip flexed and adduction. The flexed knee will need to be kept in hip flexion and knee flexion as well. We used a posterolateral exposure. The Gmax takedown was standard. The short lateral rotators takedown was standard. You identify the inferior part of the neck. Be very careful of the anterior sciatic nerve. And sometimes because of the osteoarthritis or the hypertrophy, you might need to do a sliver posterior wall osteotomy to have an actual look into the hip, and then subsequently an in situ neck cut or a sandwich osteotomy requiring a cut proximally and distally so as to create space to work in the acetabular socket. Identification of the tal, which is very often ossified, sequential reaming through the residual hip. We will always find the pulvinar or the fat pad, which tells us where is the medial wall of the acetabular socket, and then impact a templated hip into the standard hemispherical uncemented shell into the acetabular socket. On the femur side, one needs to do a 360-degree dissection, sparing the abductors. The anterior hypertrophic femoral bone needs to be taken off. The femoral pre-op assessment is very, very important to avoid a femoral neck version mismatch or a proximodistal femur mismatch. Stem choice basically depends on the geometry, and it needs to address versions, offset issues. Combined antiversion needs to be perfect. The shuck test needs to give good soft tissue stability, and you do a myodesis of the short external rotators. And it's good practice if you can to do the contralateral side also in the same sitting if there are no significant medical comorbidities. So enough article to say that these are very good practices, as in this lovely article which compared 3 different groups: no ankylosis, bony ankylosis, and fibrous ankylosis, where the small issues were because of length of stay and cost, minimal wound healing, delayed wound healing, and asymptomatic HO, which can be addressed by giving indomethacin in the postoperative period. Another patient, 21-year-old male, morning stiffness lasting a significant duration, lack of mobility for 2.5 years, backache, activity of daily living affected, and a school dropout because of the problems, which essentially were bilateral FFDs, extension abduction contractures, a poor score, and a very high disease activity with a bilateral ankylosing spondylitis of the hip. This is what he looked like. This is what his movement was: limitation of hip motion, significant fatigability, chest expansion issues, scoliosis issues, limitation of activity, and lack of integration into the daily society. This is what his pre-op looked like. We had to do stop the DMRDs. This is what his gait was. I'm sorry, video is not working, so we'll go ahead. That is his immediate post-op on one side. We waited some time, 4 months, for the contralateral side, and this was his contralateral side, and this is a happy patient 6 months post-op. Another patient, pathological fracture because of the ankylosis. You need a distal fixing stem with the standard procedure for the cup side. Another good result. So basically, the long-term outcomes are good, and they address all the issues of the problems with patients because of ankylosis. They improve their self-care ability, and the benefits outweigh the risk for problems. So the take home is that ankylosis in a malposition needs to be addressed with total hip arthroplasty. The altered biomechanics causes activity of daily living issues, and the technical challenges due to deformity in the coronal and sagittal plane are what are important. Patient positioning issues are very real life because of a dynamic imbalance due to the stiff spine and an altered spine hip knee axis. Anesthetic risks need to be addressed, surgical factors need to be addressed, and the overall treatment depends upon management of protrusio, path fracture, osteopenia, version inclination, stem factors, and the result, total hip arthroplasty, results in excellent outcomes and happy patients. Thank you for your time.
Dipak, you are muted. Right.
How often, Abhay, we need to do a dual approach in a very fixed deformities?
Dr. Bosley has described the dual approach and he's very fond of it, but invariably I don't do it. And I think in my practice, we do a lot of severe ankylosed hips. It's not something that you need to do always. It's something you can play with if you're comfortable with.
The second question, as you said, depending on the spine deformities, you have to change your version, correct?
Yes, so the hips are either flexed or they are straightened, and you need to dial in less anteversion of the cup to prevent a dislocation. So you basically need to look at the functional version instead of the Lubenick safe zone to get a safe non-dislocated total hip arthroplasty.
Thank you very much, Abhay. Can we have the next speaker is Dr. Neeraj Agrawal. He is the senior joint replacement surgeon from Jaipur, Jeevan Rekha Super Specialty Hospital. He's attached with, and he has done his fellowship in Germany. He's also a Ranawat Fellow from USA, and a very active member of the Indian Arthroplasty Association. And he's the secretary of the Jaipur Orthopedic Society. He's going to talk on the ETO, the extended trochanteric osteotomy in revision THR. Neeraj, please share the screen.
So, so you are able to listen, you are able to hear me?
Yes, hearing is no problem.
Okay. So, thank you, Team GOSICON, for giving me a chance to speak on a topic which is actually a very difficult topic to discuss. And ETO, extended trochanteric osteotomy, as we say, is actually used for difficult revision surgeries. Whenever it's impossible to extract the stem or cement or debris, then we need to resort to the measures which are described as ETO. So,
just do a slideshow.
So, well, first of all, let us go through the literature and see that from where these concepts of osteotomy started. So, if we go through the literature, we see that actually the work of Chanley was the pioneering work for the trochanteric osteotomies. He used to do it in all his cases, and very beautifully, he not only used it as an approach for the hip, but also to tension the abductors and to decrease the chances of dislocation of the hip. So Chanley actually started with the trochanteric osteotomies. Maybe it may be present before also, but as learning tells, then comes the extended trochanteric osteotomy, which was an extended form of doing again this trochanteric osteotomy, and this was used actually for a better exposure and for the indications which I will enumerate now. Also, there is osteotomy which is described by Wagner. Now, what happens is that if you can see this femur, you can see that if you put the osteotomy like this and make it from the anterior and posterior aspect, lateral 1/3 of the circumference, it is a ETO, but in the Wagner osteotomy, you need to go anteriorly, and it is slight anteriorly from the mid to the anterior is the Wagner osteotomy. So I don't have an experience of Wagner's, but ETO I do in my cases. And why we need to do the ETO? Because it improves both the acetabular as well as a femoral exposures in complex primary and revision hip arthroplasty. This is one indication. Simultaneously, we should try to remove the stem by routine instrumentation, but if we are not able to do it, then ETO is the way to remove the stem, whether it's cemented, non-cemented stem, or the metaphyseal fixing stem. And it is also essential to remove the remaining cement fragments of the distal femur, which we cannot remove either ways. It is also important if we have some broken femoral component, we don't have any other way to remove it, and we needed to sort to ETO to remove it. And also, if there is a significant anterior femoral bowing and to put a revision stem is difficult, then ETO may be used. So ETO has the indications, and definitely it comes to a rescue when nothing works for the surgeon, like for this case, which is impacted, which has osteolysis, and we need to remove this stem. And believe me, it is very difficult to do it. Now, when we do a ETO, I will briefly share a video with you, but few things which we will discuss in the video is that what should be the length of ETO, how much the ETO should be there, what should be the mode of fixation, what is the significance of isthmus, and how we should fix the ETO. This is a pictorial diagram for you. In the left side, you can see how the Wagner osteotomy is done, and in the right side, you can see how a ETO is done. And you can also see that the amount of circumference which we remove in the ETO in the trochanteric osteotomy is about 1/3 of the circumference. 2/3 from the anterior and medial aspect still remains intact. And we will now go to the video part. I will go for a new share, and it starts like this. So you can see that it is a exposure. The upper part is the greater tortuosity. I am trying to remove the stem like this, but I am not able to remove it. So now I decide that since it's not working. Now it is important to mark the ETO site, and Shyam is very important if you want to mark it, because if you put it the stems like this, you can see it like this. So if you want to do an extended trochanteric osteotomy, always remember that it should not be 10 to, I am sorry, I will mute this. I will mute the sound of this video so that. Yeah. So now you are able to listen to me. Are you able to listen to me?
Yes, sir. Yes, we can listen you. Yes.
Now you are able to listen me. Yeah. So I am sorry, but I think the bandwidth issue is there, and so it is important that when we are doing a ETO, we should first mark it on a Shyam and see whether it the tip, and always remember that we should not try to trace the tip of stem, because beneath the tip of stem there is always a cement restrictor and cement underlying it, and therefore try to put a ETO so that we can preserve the part of isthmus, because we all know that our distal fixing stem which we will put after ETO will actually take a fixation in the isthmus part. So try to maintain this integrity of the isthmus. Now, if you are once you mark your ETO from the anterior aspect and from the posterior aspect, after this put a SS wire or put a cable just beneath so that you don't damage the distal femoral integrity or inadvertent fracture or cracks propagating to the distal part of the femur. And once you do it, then always remember that you need to put it in a manner that your soft tissues attached to the part, the vastus attachment, the rich vastus attachment, they should not be disturbed. They should not be devascularized, because these rich muscles which actually will help in putting the in union of your ETO. So this is the way we have put the wire. You can see it here. And now after putting the wire, the stem, we are reaming it. And once after making an initial entry, and one more important point which is to be re-emphasized, it that please don't try to trace the distal tip of the femur, because you may compromise with the isthmus which is actually available for distal fixing stem. If you need to put generally the ETOs are from the shoulder of stem, they are about 10 to 12 centimeters and not more than this. And now once I have removed it, I have removed that cement spacer also. You can see it very well. And this is the cement which we are removing. And now after putting it, we have reamed, we have put a trial, and now we are putting a SS wire and cables, combination of SS wire and cables. You can make it out here. And once you put and you do it, you find it that you have got a very stable hip and a very stable fracture fixation. And in our experience, we have seen and you can see the pictures also here where we have put the ETO and SS wire is there, and you can make it out here that this is the gratted trochanter and this ETO is going here, multiple drill holes which were communicating, and then a saw was used, and multiple now this ETO is ready for the repair part. You can see it with these 4 pictures also, where you have a ETO, you have opened it, you have removed the cement and toto from the femoral canal, and few instruments which are important if you are doing a ETO. It is always good to have set of osteotomes, and it is always important to have patience while doing the ETO, because you are dealing with a bone which has lysis, which has osteoporosis, and sometimes the fracture lines propagate either, or you can also you can do a comminutive fracture of the ETO, then it becomes very difficult for you to fix this. So this is the after fixation. You can see that even the SS wire, you take it beneath the vastus muscle, vastus lateralis, and tight it so that they are actually not visible, and this gives you a very good fracture union. So in the cases which we have done, almost 95 to 98% union rates, literature also supports it. And it can also be done in the septic cases, because it's important to remove every tits and bits of cement which are there in the canal in the infected case, and which can lead to reinfection. So this is the all which I want to discuss about ETO. Questions are welcome.
Thank you, Neeraj. You are well on time. I have one question. Between the cables and the SS wires, you find any difference?
Yes, sir. So definitely, this is a good question, Dr. Dave. Generally, the cables which we use, it's important that the cables, the strength of cables are better than SS wire, but the availability initially was an issue. Now many Indian companies have come with the cables, and it's important that we should take the 8-stranded cables. So there should be 8 wires. It's a combination of 8 wire. 8-stranded cables should be used for ETO. And the fixation with cables, in my experience, is better than wires. But definitely cost is an issue when.
And my second question is, how soon you make them mobilize, or is there a difference in your protocol once you do the ETO, the weight bearing part? What is the change?
So since we are putting a distal loading stem, and if your fixation is good in the distal loading, then actually you have taken off the weight from the ETO, and you can actually mobilize them initially with the help of a walker, partial or toe touch weight bearing for first few weeks, and later on after 4 to 6 weeks, you can put them full weight bearing.
Thank you. Thank you, Neeraj. Our next speaker is the only flag bearer female, the giant, Dr. Mangala Borkar, who has been a very active GOSI member.
Evening, sir.
She's the professor of the postgraduate department of geriatrics at Aurangabad, and her topic is dealing with osteoporosis, a geriatrician perspective. Unfortunately, in our country, dedicated geriatricians are very few, even in the big medical colleges. But she is very key, very much expert on this subject, and has given a lot of talks in the past also. So I welcome Dr. Mangala Borkar to give her talk. You can share your screen, madam.
Yes, sir. Good evening to the esteemed gathering. Thank you very much, organizers, all the respected orthopedicians here. And I'm really grateful that you have considered me for this conference, esteemed conference of yours. Especially, I should thank John sir, Amarnath sir, and Dave sir for having given me this opportunity. As you said, yes, geriatricians are still not as many as they should be, because there are more than 14 crore elderly in our country.
Ma'am, sorry to disturb. Can you please make it in slideshow mode?
Sorry, sir. Yes. Yes, sir. Is it now visible?
And
yeah, it is moving now. Yes.
It's moving. Thank you so much. Yes. So thank you very much, sir, for giving me this opportunity. And as you said, geriatricians are few. There are about 14 crore geriatric persons in our country, almost 10% of the population, and it is increasing rapidly and likely to double by 2050. So we need more and more geriatricians, and we need more and more orthopedicians also to take care of them. Now, why is osteoporosis such a concern for geriatricians and the orthopedics eminent surgeons? You know that brittle bones break easily and they are difficult to mend. And along with the breakage of the bones or with fractures come associated complications. The person may be bedridden, dependent, may become delirious, and even may die. And the costs are high. The quality of life, depending on the speed and the quality of care that the patient gets, may be relatively quite low. And particularly for an orthopedician, you know well how difficult it is if the bones are really osteoporotic to perform any kind of surgery on the person. And they have usually multimorbidities. When they are osteoporotic, they are very frail and many complications can occur. Therefore, what can we do about it is a very important problem or an issue before all of us. Now, you know very well, I won't go into the details, the types of osteoporosis, the causes of osteoporosis, the primary causes, the secondary causes, particularly in ladies and also men. After the age of 70, osteoporosis is common. And we have to be particularly careful and we have to be very keenly observant to see whether a person has this problem, so that we can take certain preventive measures and precautions. Now, what is my role as a geriatrician in osteoporosis or in an osteoporotic person, and why am I worried about it? Because as you know that the risk of fractures is increased, particularly the vertebral and the hip fractures. By itself, osteoporosis, if the person has osteoporosis, it's okay, but the person's bones will break, and that is the biggest worry that I have. Now, how will a fracture occur? Most commonly, it will occur due to a fall. And why will the senior fall? Multiple causes are there, and those need to be assessed apart from so that we can prevent the falls. So that is very important. And the prevention is extremely important, in that we have the primary prevention, as always, for any illness. And that would start at a very young age, maybe from school. And outdoor sports, diet, prevention of addictions later on should be encouraged from a very early age, so that the bones remain fit and strong at an older age. And can I help as a geriatrician? Now, these children won't come to me, but yes, any doctor can help. We can help by spreading awareness. We can spread awareness at various levels, including through media, or through various meetings or visits to schools or speaking to people, and we can increase the awareness to strengthen the bones. So that is something which is very important and primary prevention. The secondary prevention would be mainly when the elderly persons we see around, or somebody who comes to me as a patient or as a relative, as an older person. Now, what can I do here? One important thing is that I should presume that all the elderly persons are osteoporotic unless proved otherwise. And some kind of preventive measures should start immediately. IEC, that is, you have to keep on explaining to the patient about diet, exercise, balance, maintaining balance, and prevention of falls. Now, nobody falls by choice, but there are many ways by which falls can be prevented, and that is something which we have to explain to the elderly persons. Then, as a geriatrician, I can perform a comprehensive geriatric assessment, and if needed, X-rays. X-rays are also very helpful in because see, like in my hospital, a big government hospital, but as yet we don't have a BMD or a DEXA scan. So X-rays also help us. And as I said, that every person above 60 years in secondary prevention, we have to presume that they're osteoporotic and give them the basic advice. And most important thing we have to advise them is fall prevention. That is the number one advice which we have to give. And there is a simple test, which is a tuck test, the get up and go test. The person is sitting in the chair. It is for assessing the risk of the fall. Very simple. Anybody can perform it. The person is sitting in a chair and then gets up and then walks 3 meters, about 10 feet, and turns and returns and sits back in the chair. So gets up, goes and comes back. And all this should usually take about 10 seconds. If it is more than 14 seconds, this person has a high risk of fall. And then he should be counseled to go very slowly and help himself with some like a stick, or he should carry a stick or a walker or whatever if needed, if the tuck time is too long. So these are the precautions which have to be taken, and a very simple assessment can be done. Now, in fall prevention, most important advice which we have to give the person is to go slow and avoid rushing. That is the most single kind of advice that you have to give. And then, of course, wet floors and other high-risk areas you have to tell them. And then you have to screen the patient for cognitive impairment, any neurological disorders, musculoskeletal disorders, and whether there are hearing and visual impairment, particularly visual. Then environmental issues, where he stays, what is the surface like, etc. And other things have to be looked at, and we have to guide about fall prevention. But again and again, I would humbly suggest to you that we have to tell them to go slowly, be very careful, and watch every step. So that is the most important thing which we have to tell them about. And then there are a number of causes why falls occur. There are medical conditions, medication, psychosocial, sensory motor, balance problems, environmental problems. And we have to take a good history, assess, and then try to, we can't solve everything. And that is why again and again I say the person has to be careful and go around very slowly, and the caregivers have to be informed about this. Now, very important part, the tertiary prevention, where you and I, we can work together after a fracture occurs. So I would request you, not because I am a geriatrician, I'm in the government setup, but involve a geriatrician or a physician in the pre-operative assessment along with the anesthetist, and the post-operative management also of fracture femur. Significant morbidity and even mortality can be reduced by this, because you all are busy, you all operate, then you all may go somewhere else, or you all, some things naturally, like we may pick up, which you also will pick up, but if you have that time, and otherwise it may be missed. Elders often have multi-morbidities which need to be handled. Then one request to you is operate at the earliest. I'm sure you're doing that. During COVID time, there was a big delay in our hospital, and due to various problems, and the mortality was a little high. So a geriatrician can assess delirium, prevent factors that may lead to it. And in case later on conservative management is needed, or before also, because the person cannot be operated, conservative management is indicated or planned, then in that case, the geriatrician can help with various nursing and other advice. And rehabilitation also, by supervising the physiotherapist, nutritional and psychological support, as John sir very rightly emphasized in his talk. This, of course, I don't have to show you all this, but less than minus 2.5 is osteoporosis. And these are useful, especially if you're going to give medications for osteoporosis, decreasing osteoporosis or controlling osteoporosis. Then this is the fracture risk assessment tool, in which the femoral neck bone mineral density and then the age, sex, weight, height, which are factors which cannot be controlled, but previous fractures, parents, if there is a history of fracture, those also cannot be controlled. But smoking, alcohol, steroids, RA, or other causes of secondary osteoporosis, particularly the addiction part, can be controlled, and this advice has to be given. And exercise has to be stressed. All types of exercise are beneficial, and especially gait training, balance training, and muscle strengthening exercises. Vitamin D, about 800 units needed, and particularly you may give loading doses if the levels are low. Calcium, about 1 gram is needed, and these are the various foodstuffs which contain calcium, but you can see that to get 1 gram, the quantity of milk which will have to be taken will be 2 glasses, or along with some other vegetables and all, which is very difficult. The absorption, the difficulty in eating, and the availability also. The patient may not be able to get it. Therefore, supplements with calcium would be advised. Pharmacological treatment would be the anti-resorptive principles. I will just give you the principles. The anti-resorptive, which reduce the bone loss, like alendronate. Anabolic, which produce new bone, like teriparatide, which is a parathormone analog, and dual action, like romosunab. Now, these are the various biophosphonates. Maybe you use them. I don't have too much experience with this, very little, but these are useful in increasing the or decreasing the osteoporosis, and to some extent they can reduce the extent of fractures. Biphosphonates are the first choice. Denosumab also is quite good. Anabolic agents like teriparatide should be used only when biphosphonates are tried and found not to be of much use. Then what is very important is that many of these drugs are costly, and they produce certain side effects like osteonecrosis of the jaw or atypical femoral fractures, less incidence, but you have to be very careful about it. And what is very important is that you tell the patient to avoid falling if possible. And of course, empathy, care, and encouragement at all levels would be the mainstay of treatment. Thank you very much for involving me in this conference.
Thank you, Dr. Mangala. Madam, you are always on perfect timings, and a nice insight in the how you see the geriatrician from your point of view, because we only see the bone, you see the whole patient. So I think that's the difference. We thank you for spending time and giving your valuable inputs. Our next speaker is like Dr. Mangala, who is a non-orthopedic. We have another guest from UK, Dr. Harun Gupta, and he's a consultant radiologist, clinical supervisor in the Leeds Training Academy, and senior lecturer at the Leeds University. We have been able to get Dr. Harun Gupta here because of Dr. Shrikant, who is also a very active GOSI member. His talk is after this. And on behalf of the organizing committee here in Ahmedabad, me and Dr. Bharat Dave and our GOSI Executive Council, it's my pleasure and privilege to welcome you, Dr. Harun, for your talk on geriatric bone, a radiologist's perspective.
Good evening, everybody. Can everybody hear me? Is everybody able to hear me?
Yes, we can hear you. Just little loud, please.
Yes, yeah. So I will speak a little bit louder. Yes, please. Yeah. First of all, I think the topic of the talk is geriatric bone, a radiologist's perspective. So, sorry, my slides are not moving. 1 second.
Tap anywhere into the slideshow, and you will get the slide moving.
Oh, okay. Let's just come out.
Now the slide should move.
Yes, I think you can you see my slide now? Yes. So essentially, first of all, a very big thank you to all the organizers. A big thank you to Dr. John Ebnezar, Dr. Shrikant, Dr. Dave, and all the organizers for having the radiologists come to this meeting. It is always a pleasure to come back and speak to any meeting in India, and I'm delighted to be part of this meeting. So what I would like to cover in this next 12 minutes very quickly is we will look at the bone changes in radiology in the geriatric age group. We will look at osteoporosis. We will also look at problems related to the treatment of osteoporosis with bisphosphonates. And when the time permits, we will look at some of the common fragility fractures, especially the pelvis and the spine. So we all know that the geriatric population around the world is rapidly increasing, and there is also an increase in the number of musculoskeletal disorders in this population. Important thing to understand in elderly population is that even a trivial trauma can produce severe unstable injury. And sometimes because the trauma is trivial, it leads to underestimation of the severity of the injury, and it can produce increased morbidity and mortality because of delayed imaging. So what happens to geriatric bone, we all understand is that the people start losing bone mass and density as they are aging. Already, it has been mentioned that women lose much more immediately after the menopause. There is loss of calcium and other minerals. And if you look at the comparison here, this is the normal bone here, and this is the osteoporotic bone. So as we age, there is increased incidence and problem of osteoporosis. So radiology plays a very important role in workup of these patients, right from when before the problem and even after the problem. So plain radiographs, CT scan, MRI scan, and DEXA scan all are very, very useful for evaluating these patients. So osteoporosis, as we all know, is characterized by low bone mineral density. It leads to affection of the microarchitecture of the bone, and importantly, what it does is it makes the patient susceptible to fractures, and this is much more common in women. We have to remember that immediately after menopause, in the initial years, the bone loss is much more as compared to later ages. So now coming to the radiology part, starting with the plain radiographs, because these are often the starting points, but we have to remember that for osteoporosis, conventional radiographs are slightly insensitive because we have to lose nearly 30% of the bone mass before these things manifest on the plain radiograph. And a plethora of changes are seen on plain radiograph, right from ranging from radiolucency, which is quite commonly what we look for. There can be increase in the thickness of the trabeculae, an overall decreased number, cortical thinning. There can be frank insufficiency fractures, and in the spine, there can be wedge fractures and compression fractures. So this is an example here. If you look at the radiograph, the bones are barely visible. There is diffuse osteopenia, and on the right side is a sagittal reformat of a CT scan, which shows an established fracture in the L4 vertebral body, which is the typical compression type fracture. And on the last side is the image here. There is diffuse osteopenia, and there are early changes. We can see early bowing of the end plate. So these are the early changes which can be sometimes seen in the plain radiograph. Now, DEXA scan has already been mentioned, and this is the mainstay of evaluating these patients for diagnosis of osteopenia and osteoporosis. It's a very straightforward scan. There is no claustrophobia, no problem in doing it, and the values are evaluated in the region of lumbar vertebrae and in the femur. So important thing to remember in the DEXA scan is the T-score. We don't worry about the Z-score. Z-score is for younger population. In T-score, what we're trying to calculate is the various standard deviation. If the standard deviation is less than -1, it's normal. In between -1 to -2.5, diagnosis is osteopenia. If this is less than minus 2.5, it's osteoporosis. And if it's less than 2.5 and the patient has a fragility fracture, it goes to severe osteoporosis. So this is an example here. This 75-year-old lady, she has got osteopenia. She has osteoporosis on DEXA scan, and then she has a trivial fall, landing a distal radial fracture, which puts her into the category of severe osteoporosis. An important thing which is happening is the bisphosphonate treatment. And this was an article we published in the British Journal of Radiology. It's open access article, and I was one of the senior authors. So it's easily accessible. They can look at it. But the important thing about bisphosphonates is these produce very typical fractures. So what happens in bisphosphonate is the fractures happen in the lateral cortex of the femur. The insufficiency fractures, the fractures because of vitamin D, they are all on the medial aspect, whereas the bisphosphonate fractures are on the lateral aspect. They are in linear plane, and we can see here the endosteum and the periosteum both are affected. Important thing also to remember is that these patients can have bilateral fractures. So example, in this patient has a fracture on the left side, and on the right side has already got complete fracture. So if you see a fracture on one side, important to screen these patients with the other side as well. Now coming very quickly to the insufficiency fractures in the pelvis, which is very, very common. And these are the insufficiency fractures in the pubic rami, which is an important area. But one of the most important areas is the sacrum, where we often see non-traumatic insufficiency fractures. And these affect sacral ala, and these can affect the body of the sacrum. And typically on imaging, they have an H-shaped configuration, sometimes called as Honda sign. But do remember, sometimes all we will see is early insufficiency fracture changes and not the complete Honda sign. Now, this is a very important area, which is the hip fracture. This patient came with trivial fall and right hip pain. Nothing really was seen on the imaging. Patient continues to have symptoms. 3 days later, it is realized that the patient has a displaced subcapital fracture, which was missed earlier. Just to give you another example, patient has come with trivial fall, elderly patient, nothing much seen on the plain radiograph, possible lucency, possible synovial herniation pits, no displaced fracture. CT scan is done again. There is no definite fracture on the CT scan. Patient continues to be symptomatic. An MRI is done. An MRI shows an undisplaced subcapital fracture. So key point to remember is that the negative radiograph does not exclude undisplaced neck of femur fracture. When there is clinical concern, patient is not able to mobilize, we should do further imaging. The radiograph sensitivity is a bit limited. And if you look at the guidelines which have been published by various authorities, MRI is the gold standard. But if MRI is not available, CT scan should be done and ideally reported by a musculoskeletal radiologist. This is a study we published recently in Leeds. This was presented in one of the conferences where we looked at the dual energy CT scan. So what dual energy CT scan do is it can pick up edema. So if you look at this 96-year-old patient with a fall, we suspect that there may be a sacroiliac fracture, but when we do the dual energy CT, we can see the edema, which is the white part as compared to the other side. So it helps us increase our diagnostic confidence. And this is a patient with a traumatic bilateral insufficiency fracture in distal tibia. So do remember, when a traumatic fracture happens, keep a low threshold for imaging. Plain radiographs are not very sensitive and they don't pick up these fractures. MRI is the gold standard, and as already mentioned, always work these patients for bone profile and appropriate treatment, otherwise they will not heal appropriately. So spine injuries are very, very common in elderly population. The risk of fracture doubles with each decade after the age of 60 years because of osteoporosis and rigidity, because of dish and degenerative changes or ankylosing spondylitis. So again, in this age, in this particular group, when there is spinal imaging, keep a low threshold. CT is the first line investigation, but sometimes we have to do MRI, especially in patients who have degenerative changes or who have dish, because there is risk of cord injury, even in the absence of radiological absence of trauma on CT scan. So this is an example here, severe degenerative changes, and there's not really much we can see on the CT scan. But if you look very subtle, there is possible some changes at the C6-7 level. Patient is symptomatic. We do the MRI and we realize there is complete damage at the C6-7 level of the ligaments, and there is complete central stenosis. This is typical osteoporotic fractures in the spine as they look, which can be seen on MR imaging. And this is an example of a fracture in a fused spine with dish. And look at the unstable fracture with widening of the gap and edema at the site. And this is an unstable fracture. And this is a patient with severe degenerative changes with trauma. There is severe ligamentous injury, and then there is cord injury as well because of severe spondylotic changes. So what I would like to say is that teamwork is what wins. Orthopedic surgeons obviously are at the forefront of treatment, but there is also need for up-to-date information about the bone quality and imaging, and very important to know about the post-treatment management to help the patient completely. Very quickly, I will say I have published a book on soft tissue tumors recently, and this is a book which covers, it's a very, very handy book, which covers everything about the soft tissue tumors. So anybody interested in tumors can have a look at it. And I've also launched a very innovative website for teaching MSK radiology. Thank you all very much.
Thank you, Dr. Harun. I think it was excellent talk. My one question is, how often do you resort or do you need a bone scan? Is there any role for any stress fractures or anything to go for a bone scan?
I personally would not recommend a bone scan, to be honest. MRI is the gold standard imaging. And if the patients are struggling because of mobility or they are unable to lie still in the MRI scanners, means that is the area where, but bone scan, again, they have to lie still. And then it takes a long time. It takes, they have injection. My preference, I would suggest, is the MRI scanner.
Okay. Dr. Bharat, any question? Dr. Jha? You unmute yourself. Dr. Jha, please unmute.
Importance of plain radiograph in diagnosis where facilities for DEXA scan does not exist. So if you have advised radiograph of a spine lateral view, can we still grade the osteoporosis?
I think that is difficult because, as I already mentioned, that the plain radiographs are less sensitive. There has to be almost 30% loss of bone mass. Plain radiographs are helpful where you will be able to see established fractures. You might be able to see indirect things like bowing of the end plates, smaller node formation, sometimes early loss of end plate heights. And these are indirect signs. Obviously, you will see radiolucency, but these are the things which we can pick up. Obviously, if you pick up an established fracture, then immediately you know that there is osteoporosis. But if there is no established fracture, then you're looking at signs like radiolucency, bowing of the end plates, loss of end plate heights, smaller node formation. And these are the things which can indirectly point towards osteoporosis.
Dr. Harun, my question may look a little silly, but do you think that in this digital X-rays, the exposure of and the plate which we get from the radiographer also makes a lot of difference in the seeing the X-rays as an orthopedic surgeon?
I think you're right. Actually, the dose for the lumbar spine X-rays is much higher. Actually, quite high. The patients get a higher dose. But see, in elderly population, the other important thing is we're often not worried about future cancer. We are worried about making sure that we pick up the right diagnosis at the right time, because delay in diagnosis can lead to more morbidity and mortality.
Okay, thank you. Thank you very much, Dr. Harun. And our last speaker of the day is Dr. Shrikant KN, the specialist surgeon from Bengaluru and the chief of the SSOC, mainly interested in robotics and reconstructive surgeries. His main interest. He also has been conducting routinely the arthroplasty courses and the other academic activities, is involved with the eminent surgeons from UK. He's going to talk on a new subject, the role of artificial intelligence in the healthcare. Shrikant, over to you.
Thank you, sir. Thank you so much. Let me share my screen. Can you see the screen?
Yes, we can.
So, just go to the slide view. Right. Good evening, all. I welcome all of you to this presentation on artificial intelligence in healthcare and orthopedics. Is it a boon or a bane? GOSICON 2023, Jaipur, now it's a virtual event now. At the outset, I'd like to thank Dr. John Ebnezar and the GOSI team for the invite, and and also thank Dr. Gupta, my friend, for coming all the way from Leeds. Thanks for the hospitality. It's a shame we couldn't meet physically. We're really looking forward to meet all of you and meet our GOSI family, really. Man proposes, God disposes. Very grateful to Dr. Dipak Dave and team and OrthoTV team to make this event possible. In the original live meeting, I think I had 8 minutes. So when I read the brochure and reread it, I was surprised to see 20 minutes. And knowing Dr. Dave, sir, very well, he knows where the time has to be spent. And I'm grateful for these 20 minutes. I have converted the 10 minutes PPT into 20 minutes as a full talk to 40 minutes yesterday. Some padding, but very useful padding, which will benefit all the orthopedic surgeons in India, has been done. So let's start. Right. So this is AI in healthcare. As sir mentioned, a consultant robotic reconstructive surgeon at Association Clinicals Group of Hospital in Bangalore. And at the outset, I take this opportunity to welcome all of you to the Bristol Hip Orthoplasty course 2023. That's happening on the 30th November and the 1st December 2023. That's World AIDS Day. We can't forget 1st December. There's a link to the register for this event. Kindly take a snapshot of this or screenshot of this thing, so you can register for this. It's live and open now. And I'm very happy that my mentor Everett is wanted to address the gathering, and there's a quick welcome to all of you. Just play it.
Hello, everybody. Everett Smith here. I would like to welcome you all to join our meeting in Bristol, the Bristol Arthroplasty course this year, which is held on the 30th of November and 1st of December. It would be fantastic if we had a massive virtual audience from India and everywhere else in the world, as the face-to-face meeting itself is packed to the rafters. The wonderful thing about this long-standing boutique course is that it is extremely interactive, where we provide information which can be coalesced into knowledge. It is a great hip course and is made possible by my co-coordinators, David Penford from Clockwork, and of course the great work from Doctor in India. Please join us this year at the Bristol Hip Arthroplasty course. Thank you very much.
So this is the program. I think this is where the future of orthopedics is going. This is called as, patient-centric surgery or precision surgery. So that's what we are discussing: precision planning and execution in orthopedics, impact on patient care and the outcomes. And this year I'll be participating myself in the meet there. And I thank my friend Dr. Harun Gupta for coming for this meet, GOSICON, all the way from Leeds. A great meeting yesterday. Went into the complete depths of AI in radiology and orthopedics. Let's go through a shortened version of the same, really. So thanks, Dr. Harun, for coming here. We know that AI is already helping us in diagnosing diseases, planning treatment, patient education, and medical research. I love basics, because if the basics are strong, then our, the buildings are going to stand for a long time. So let's look at what is AI, what is artificial intelligence. Definition. Basically, it's intelligence demonstrated by a machine. What is intelligence? Intelligence is ability to acquire and apply new knowledge and skills to get new insights. AI helps improve decision-making by doctors, can summarize 10-page patient history in few minutes, help analyze the symptoms and patterns, helps even patient to make decisions. We all know about the Google patient, and as doctors, we are fed up. But the Google patient is dead now. Now we have got the Chat GPT patient. He's going to go to AI, put all the symptoms, bring reams of things, to tell us what is the treatment. So, and now the language is no longer a barrier. Earlier, the paper in Chinese, I used to just neglect it. But now the Chinese paper can be converted into English and we know what it is. Big tech giants like Google are trialing AI systems like the MedPalm 2, which huge neural networks with 1 trillion parameters at places like the Mayo Clinic in the USA. The CEO of the Mayo Clinic was on air just a couple of days ago, and he says the trial is going well, and he's looking for the exciting future. Very important for business or hospital owners because it saves money on repetitive work, and some of the junior level staff can be replaced. Let's look at the evolution of AI. Is AI new? No, it's almost 400 years old. It all started in 1642. Dr. Pascal invented the first mechanical calculator, which is as big as a brick size. So that is the basis of computers, and it all started there. In 1940, Walter Pitts worked on the neural networks and tried to make machine which worked like a human brain. In 1942, Alan Turing, he created the bomb machine to crack World War II code from the Enigma machine, which all of you are quite familiar with. 1950, Turing test for machines became a standard. 1955, John McCarthy, is called the father of AI, coined the term artificial intelligence. 1960 to 1990, was called AI winter because the grants died. We all have seen in the last 72 hours, without grants, nothing can happen. So time had not come. And now in 1990, cloud and semiconductor era started. Both Maslow and Moore's worked on it. And a beautiful law was said, that Moore's law, that every 2 years, chips half in size, but double in capacity. And this law is a beautiful law, and it's true even today. This is the bomb machine from Alan Turing, and this is the neural network with Walter and Pitts created. So let's go back to, again, the basic definitions. Is algorithm AI? Algorithm is a step-by-step guide to solve a problem. It's basically a flowchart. What is AI? AI uses algorithm and is intelligence demonstrated by the machine. So which can self-lead by machine learning process and performs tasks independent of human intervention, while algorithm needs a coder. AI needs no coder because of ML. AI uses quality data, which is fed, and the machine learns to create new insights and newer ways of working. Data is the king of the new oil, as all of you know. What are the levels of AI? Professor Nick Bostrom from Oxford wrote the book Superintelligence. He showed 3 levels of AI. First is the artificial narrow intelligence. Give the data, and this is basically an excellent pattern recognizer. Excels at precise, defined single task, not multiple tasks. It can, for example, create a video from a text. We are in this level in 2023. Next level is artificial general intelligence, where AI reaches human level of intelligence and can reason, argue, memorize. So you all seen the Terminator movie. I grew up watching Terminator movie, and it is where it can argue and say what it wants to do. So we are not there. And the last level is the artificial super intelligence, where AI has entire human cognitive intelligence. AI as God. There's a beautiful Hollywood movie which came just a few weeks ago called as The Creator. All of you, I recommend it highly. Nicely shown how AI evolution is going to happen. So humans don't want this. There's a blockade at UN for work at this level. COVID has unleashed, and the world and its leaders were mute spectators, are very reactive, not proactive. So having seen that, interesting times are ahead. Levels of automation in health. First is human level. That is, a doctor sees a patient, intervention is by humans only. Second is shadow mode, where doctor does all the work, but facilitated by the AI, which shadows us. We are in this level in 2023. Next is AI assistance. AI is your companion at this level. You need to learn how to operate AI. Next is partial automation. Everything is done by the AI. You just say good or bad for AI to learn through machine learning. So the final is fully automation. There's 100% work done by AI. No human needed. It's not a safe level. There's a paper we discussed. 1 radiologist with AI assistance is equal to 5 radiologists. Dr. Arun went into details yesterday. I don't want to go there. AI is everywhere, in our chatbots, in movie streaming, in our car parking, where autonomic number plate recognition, banking, stocks, fraud prevention, autocorrect on our WhatsApp, healthcare. It's already there. How AI works? Learn, reason, interact. Basic principles of AI. Anticipates and does pattern recognition. Machine is fed quality data. All the data, is a binary system, 0 and 1 in computers. Like, for example, a cat is a series of pixels, and that's converted into 0 and 1. And with the quality data, ML creates its own strategies, and we say good or bad, and it saves us. What is ML or machine learning? Let's look at machine learning, types of learning. One is supervised, like kids. We have the full history, we have investigations, and we are told diagnosis, and in exam we say the same thing. AI can do the same thing. And then sometimes you even don't give diagnosis, it can come up with the diagnosis. This is supervised. Next is unsupervised. AI uses algorithm to learn. Third is reinforced learning, data with algorithm, mature learning. Humans say good or bad, and the AI stores it through machine learning. The final level is the deep learning, human neural network based. It's basically, if there is a darkness, you code AI to say, hey, produce light now. Okay, then it switches the lights on. But it can't differentiate between night, or if you come in between light, create shadow, it thinks it's night, and again light is shown. So anyway, deep learning is at the core, and and artificial intelligence is at the outside of this whole process. What are the subtypes of machine learning? One is generative adversarial network, GAN, very, very important. I'll explain that in the next picture. Second is a federated learning. All hospitals are collecting data. Governments will come after the hospital, say, please give the data. So this is the future. Hospital can't disclose because of confidentiality and fear of litigation. The hospital A picks up a subset of data, churns results without confidentiality breach, and gives it to the government. This is federated learning, what to share with the government. It's another machine learning method. This is how the GAN works. It contains two algorithms, generator and discriminator. Generator is our painter, like a Picasso. It creating output. And the goal is to fool the discriminator. Discriminator is our detective. It was trained on real data set. Its job is to tell generator if the output is created is valid or fake. They play a zero-sum game. And if the generator fools the discriminator, it wins. If the discriminator catches the output as fake, it wins. They teach each other through this zero-sum game, called as unsupervised learning. This is how machine learning occurs. Why AI in healthcare is a game changer? Because of these 15 reasons. We are in the digital era already. We can't manage terabytes of data. Big data doesn't need empathy, intuition, creativity, human expertise. So best given to AI. AI can assist humans in meaningful interpretation of data. Speed of analysis. Artis AI company can diagnose a heart disease in 15 seconds. Who can beat that? Quality in analysis. Checks WX radiology. AI company can report 420 images in 1.5 minutes. The same, human beings took 240 hours to report. Complexity in analysis. Complex protein folding and drug design can be done in 100th the time as humans. Public health. Canadian Blue Dot AI company already used in COVID. They used the flights data and told how many patients spread in Canada when the COVID outbreak happened. Finding unusual associations. For example, looking at retinal scans and finding cerebrovascular risk disease, or looking at clinical photos and finding the syndromes. And addressing doctor shortage. WHO expects 10 million doctors to be short by 2030. The patients, instead of waiting, they can use chatbots to address their basic questions, then meeting a doctor, because a doctor is becoming a scarce commodity. Make quick decisions. Give history, family history, investigation, medicines data, and then it predicts and prevents septic shock. Great thing for the anesthetist. Use patient's voice to diagnose, say, Alzheimer's, cough to diagnose COVID, skin lesion to diagnose malignancy. And make doctors' life easier, particularly in ICU. There are 200 alarms, and it said that 90% are fake. Deliver the top 10% of critical alarms to doctor to get rid of the bleep fatigue. Otherwise, it can drive doctors mad. No more lab testing of drugs on humans. Silico clinical trial. Try drugs on 3-dimensional simulated models. And self-learning. Unlike humans, it doesn't make any mistake. It is said err is human, but forgive is to divine. What are the disadvantages? Fears. Do I need to fear AI? No. Will it replace doctors? No. How it works? It's very complex. You don't need to understand how to manufacture Tesla to drive a Tesla. Just learn how to drive AI, how to use it. Can healthcare be automated? Already it is. How to embrace, play, utilize, and practice. Comfortable with AI system, particularly juniors watching this, you get better jobs if you are AI trained. What are the ethical social challenges? This is from Google. Do they understand, how is our data confidentiality kept really? What are the disadvantages? Practical considerations. Doctor take time to trust any new technology. Completely correct. Bias in AI. Derma cancer based on white skin may not detect cancer in dark skin. Need to work on that. AI has to pass evidence-based tests like all other new technology. Data feeding errors. It can be done, addressed by doctors, annotators. Privacy. I talked about federal learning is the answer. Cybersecurity. Proper laws has to be passed, particularly Indian government. Deepfakes, can mimic us and our voice. We need to find and avoid. Mistakes and legality. Can you sue AI or the company? AI is a stethoscope. Can you sue stethoscope? My lawyer was involved in yesterday's meeting. She said you can sue the company, but not the AI itself. Philosophical issue, black box paradox. We know the input, we know the output, what AI does, but we don't know what happens in between. That's called a black box. Ethical issues, the AA trolley, if there are 5 kids playing on a railway track illegally, where train normally comes, and there's 1 kid in the parallel track where train never comes, but there is a connection. Do you kill the 5 kids, or do you kill, the 1 kid which is legally playing, in a track? This is called as a AA trolley. Is AA conscious? Has it rights? Has it got privacy? Can AA vote? Some European countries are passing laws to protect AA rights already. So this is how the world is going. AA in orthopedics, not much at this time. Omnibot, uses AI and machine learning data. And I think Dr. Dave is involved in one of the Meet the Masters, I think a year or 2 years ago, when Prof. Acharya talked about the Omnibot. And I think I don't think the other robotic systems are using, but once one corporate uses Corin, I'm sure others will copy soon. RoboDoc uses AI to drill femoral peg holes in TKR. AI can tell which patient will get 80% pain relief after TKR versus who will get 50%. This is the beginning of the personalized medicine or surgery. AI reached human level of accuracy in fracture diagnosis in Sweden recently in a paper. AI as a second opinion to casualty doctors, not to miss any fracture at night, for example, like a scaphoid fracture. OptoTrack 3020 uses AI-based infrared tool to find bones intra-op to put pedicle screws. What's going to be the role of surgeon in the future? He may get reduced to that of a pilot. Takeoff and landing. Rest is AI-controlled autopilot. Which branches will survive? It's a $1 million question. Repetitive and data-driven jobs will go. Creative and patient interaction-based jobs will stay. Other jobs, mixed results, really. So Moravec paradox is very important. What is easy for AI is difficult for humans. What is easy for humans, like nursing a patient, is very, very difficult for AI. How to retain our job in the new AI era is a $1 billion question. We need to embrace AI, then fight the AI. Doctors will not get replaced by AI, but there is a caveat to this. Multitaskers will survive. These are the 10 essential skills to survive in a digital AI era. So hence my center started digital coaching. We invested in AI. AI Polaris is coming to us this Diwali. I'm going to name it as Dipak, the light, as it's going to replace repetitive jobs done by the reception or by some junior doctors. As doctors, we are very knowledgeable. We want to give everything. In coaching, we only give, what a person can digest. So there's 4 domains where we are starting the coaching, from patient to junior doctor training, to legal, and then to spirituality. And there are 4 levels: silver, gold, diamond, and platinum, where there's one-to-one coaching. All details are there in my website. In the landing page and the banner, there's a form. If one fills, my team will be in touch to help with coaching, including AI coaching. So as Albert Einstein said, true sign of intelligence is not knowledge, but imagination. So I think this is going to be the future, and I welcome any questions. Thank you very much for the patient listening.
Thank you, Dr. Srikanth.
Thank you, sir.
I think, as you rightly said, Bharat's talk was also something similar to this, enabling the technology. So it's a way forward, whether it's a navigation or it's OARMs or robots, whatever it is. But I think like the next is AI. We have to be careful about few things which you have mentioned, because ultimately you have to take the decision. But I think it's a way forward, and you are much ahead of others, it looks like, working on this. As you said, in Diwali, you are going to implement few things. So good luck to that. And I think it's a nice, different topic which you covered on this. Today, on the Friday, we are just completing the first session of the scientific meeting. We're about 5 to 7 minutes ahead of this. I take this opportunity to thank all the faculties and all the speakers, those who spared the time and presented their work here, all the delegates and the viewers, those who have been seeing online on OrthoTV and on the open link, and at the same time, the sponsors, Acumentis, Stratos, and OrthoTV. Tomorrow, we have another exciting day. Again, it will start at 4:30. We hope to finish at 7:30 like today. We have quite interesting talks tomorrow, including the GOSI oration, which is to be given by Sergio Rovansky, the shoulder specialist from Brazil. We have the speakers from UK, Egypt, and Brazil tomorrow. Again, it's a very interesting program which has been lined out. I hope to see all of you tomorrow, along with my colleagues, Dr. Bharat Dave, Dr. John Ebnezar, and Dr. Amarnath. And I take this opportunity to once again thank you all and say good night to you.
One quick word, Dipak, one quick word.
Yes.
It was very well organized. It went like a clock precision and absolutely entertaining, educative, knowledgeable. I didn't even get up and go to the washroom. I was just sitting glued on my seat. The talks were excellent and fantastic organization. Dipak, I salute you. My hats off to you. The way you have conducted this online, it's so entertaining and so nice at the comfort of our home office. We are sitting and getting so much of knowledge. And the last talk by Shrikant was outstanding. He is way ahead of his time. You know, the way the courses what he is conducting and the way he brings the international faculties to India and his thinking ahead is astounding. I'm so proud of him. I really congratulate him and I congratulate all the speakers today. They did a great job, and even Dr. Bharat's outstanding presentation where he showed how the OT should be. Mind-boggling. At least I cannot think of in this generation, in this lifespan of mine. Thank you very much, Dipak. I'm sure that it will also to be a sellout conference, and today was a huge success, and it is the credit goes to you and Bharat. My salute to you.
Bharat,
thank you so
from
much.
you want to talk, Bharat?
Yeah, sir. I think it was Dr. Dipak's wholehearted, full input, and you both gave us that, opportunity. And particularly Dipak Bhai put just, 3 days. He was just all the time. You have seen all the messages. So it's credit to Dipak Bhai only. I think.
Yes. No. It's credit to you also, Bharat. You are also a big source behind us. A great source of knowledge, strength, courage, moral support, everything.
Yes, sir.
Everything. Yeah, Dipak is the face and you are the body behind. Fantastic Dave team.
Yeah, fine.
Thank you.
We'll see you tomorrow. And
yes.
Okay, fine.
Thank you, sir. Thank you.
Good night,
Thanks.
good night to everybody.
Bye, Shrikant.
Bye.
Bye.